Marathwada University of Aurangabad, Maharashtra, India, through its Department of History and Ancient Indian Culture, is proud to organize the Indigeneity and Pandemic Past and Present Cross-Cultural Experiences webinar through this online portal of Google Meet. This seminar is actually sponsored through two different bodies. One is Wellcome Trust UK, through which Dr. Sengar already has a project, and Rural South Asia, which is an online platform connecting all the scholars and interested academicians working on the themes related to rural South Asia and the indigenous communities globally. This is the second day of our webinar. Yesterday, we had the inaugural session and the first panel on the pandemic in the past experiences. Yesterday, we had the presenters, Professor Miguel and Professor Maria Luisa Vaisaga from Florida International University and Mexico, along with certain discussants, Dr. Ghosh from West Bengal, Jalpaiguri. Yesterday was a wonderful session with the inaugural session by Honorable Vice Chancellor, Professor Pramod Yole sir. He gave us some steering comments, and those all comments were well discussed during the session as well. Today, we have some more distinguished speakers from different parts of the world, especially from the United States of America, directly working with indigenous communities of Native American societies. The theme of today's seminar, or what we preferably like to call it as a webinar, is Combating Pandemic in Post-Colonial Indigeneity and State Response in the 20th Century. So for this session, these presenters are going to speak about what are the different methods through which the pandemic was being combated by the different state mechanisms, not only in India, but different parts of the world as well, especially in context of United States of America, Africa, and certain parts of South Asia as well. The four distinguished speakers for today are Dr. T.G. Patel, Dr. Tvli Jacob, Dr. Tinnie, and Dr. Jayanta Bhattacharya. All these four distinguished speakers have extensive ground level experiences of working with indigenous communities and with their health systems. I will briefly, rather talking about each of them right away, I will introduce them individually as their presentations will happen. We have four these distinguished speakers. So today's seminar today's webinar minute-to-minute program will be as likewise. Firstly, we'll be having Dr. Patel speaking, giving his presentation. Following him will be Dr. Tvli Jacob. Following him will be Professor Tinnie, and following him will be Professor Jayanta Bhattacharya. So to begin with, I'll begin with the introduction of Professor T.G. Patel. Dr. T.G. Patel is one of the senior most scholar who has equal amount of interest both in social sciences as well as comprehensive experiences in the medical sciences as well. Today's presentation of Dr. Patel is on Sevak project in epidemics and pandemic. Dr. Patel is the founder of Sevak Foundation, which is working both in India and in the United States of America. Dr. Patel's profile is long, so I'll try to read a short bio of him. Dr. Tagore Patel, MD, currently serves as an adjunct associate professor of medicine at the Uniformed Services of the Health Sciences in Bethesda, Maryland. Dr. Patel is both certified in both internal medicine and nephrology and is a master of American College of Physicians. Following his training, Dr. Patel joined the US Navy, where he served with distinction and received numerous awards for his service of 23 years. On retirement from Navy, Dr. Patel joined the Department of Veteran Affairs in Washington, D.C. as the Program Director for Renal Disease, Diabetes, and Oncology, where he was instrumental in the developing and implementing critical policies on cancer, vascular access for hemodialysis, and hemoglobin A1 standardizations. He retired from the federal services in March 2016 to devote more time to healthcare in the villages of India. To accomplish this, he created the Sevak project to bring to bring access to care by utilizing the Navy Corpsman model, similar to the use of physicians' assistants in the medical office. The selected individuals are trained and supported by the staff of Baroda College in the implementing education, screening, and healthcare, tracking programs in the assigned villages. This project has been in place since June 2010. Sevak project is now in over 110 villages in 4 states of India and has now expanded to 10 villages in Guyana. The Sevak project has now garnered award from the GoPio and API organizations for the valuable work being done. Sevak project has become all things to the villages by providing clean drinking water, building reverse osmosis water plants, sanitary napkin factory to improve female hygiene, two swimming centers to provide livelihood to local women, screening for TB, screening for anemia in girls 11 years old to women 40 years old. During COVID pandemic, Sevak are certified to help the government and private programs to curtail the epidemic. So with this very short bio, in fact, I haven't read the complete bio of Professor Patel, Dr. Patel, who has a distinguished career not only in academics and US Navy welfare, but also for the social welfare, not only in United States, but extensively in India. And I could say so because I have worked with him on various platforms. I would also like to introduce to you all Dr. Dennis Friedman, who is going to be the discussant for today's panel. Dr. Friedman, just a second. Dr. Friedman, Dr. Dennis Friedman is Professor of Anthropology, Department of Global and Indigenous, Global and Sociocultural Studies at Florida International University, Miami, Florida. He's a medical anthropologist specializing in Native American health and sociocultural factors for global pandemic of type 2 diabetes. His experience he has experience of working with the Florida Miccosukee, Alaska Inuit, Oklahoma, Delaware, Plain Apache, and Cherokee communities. He's the founding director of the Global Indigenous Forums, and he worked as a director for the academic body in Florida International University from 2013 to 2020 with a mission to bring the indigenous voice to FIU and the world. So with these 4 distinguished panelists and 1 distinguished panelist discussant as well, we begin with the presentation by Professor Patel first, and I would like to invite now Professor Patel to begin his presentation.
Thank you, Bina.
You're audible, your voice and your video both are excellent. So
I'm trying to bring in the presentation now.
Okay, so you have to just click on the present now and then, okay, let me just help you until it comes.
I did that already.
Okay, just a second. Yeah, let me just check. Dhanraj, you have to chip in as well. So can you just click on the present now option and then you will get 2 windows there.
But I did that. It says share your entire screen, but
no, there is there's an option below. It's available. Yeah, there's a second option on the present section. Go for a window.
Okay.
And when you will click on a window, there will be 2, 3 windows, whichever you want to go for. You can go for your PowerPoint window.
Can you see it now?
No, we can't. Can you try again?
Not yet, huh?
No, not yet.
Oh, here it is.
Okay. You have to click it and then it will be done.
Okay. Can you see now?
Yeah, now it's coming. Yeah, it's coming.
We are good.
Yes, yeah, we are good now.
All right.
Can you just move a little bit of cursor so we can see whether we can see all the slides or not?
Can you see now?
Yeah, perfectly. We can see it now.
Oh, good.
Yes, all good.
Thank you, Bina, for the introduction and inviting me to speak on this subject. This is a subject that is very close to my heart. because we started this project in 2010. And ever since then, things have changed. Sevak project is Gandhian in nature, because healthcare for the villagers, of the villagers, and by the villagers. Basically, I run the project from United States. So all the people that are there are running the project. We have Sevaks in the village, then divided the state of Gujarat into 4 zones: north, south, central, and west. And each zone has a coordinator that goes to each village once a month. So they have roughly 8, 9 villages, or maybe even 10, 12 in some cases. And they would go and do troubleshooting, help the Sevak with any needs. This project is based on the US Navy model of independent duty corpsmen. Some of you may not be familiar who are these independent duty corpsmen, but these are medics. We call them medics. They're 18, 20, 21-year-old kids that we train them for about a year in healthcare, and then put them on cruisers, destroyers, all kinds of platforms, including hospitals for training, refresher training, things like that. And I was the director of this program when I worked with the Surgeon General's office in the Navy. We had about 1,000 independent duty corpsmen. And when I saw that in India, there was a problem of how to access care in villages, I looked at this program and said I could miniaturize this program and put it in the villages. So in the beginning, not knowing what's going to be the problems that I might encounter, we took 1 village per district of Gujarat. At that time, there were 26 villages, 26 districts. But now there are 33 districts. So we expanded the program. And once the Sevak completed his village in survey, he would go to the neighboring village. So that's how we have over 100 villages now. The average population of the village was about 1,500 to 2,500. And Sevaks were identified with average education of 12th grade and above. In exception, we do have a lady who is only 10th grade, but she's very bright. One of the hallmark of the Sevak project is the Sevaks have to be living in their villages. And they'll be screening for diabetes and hypertension, along with recording other health care problems. They're also required to educate the village folks about the merit of having in-house toilets, smokeless stoves, ventilation to be on the outside. This smokeless stove issue is almost resolved now in most of the Indian villages because the government gave them free gas stoves. But it's still prevalent. And the other issue was vaccination, to make sure that children are vaccinated and all. Now, how did we do the requirements? One of the things that we do in the Navy is come out with requirements and develop requirements. You just don't have. We in the United States have this tendency to go to India. This is not the current audience group I'm talking about, but my friends and other people, particularly the doctor group. They think India needs this, India needs this, India needs this. We can fix India. But 99% of them have no clue what India needs. And so one of the things that we did was create this pilot program to figure out what the requirements would be. But we also did a study of Indians in 6 Tamil Nadu villages, a study in Karakari, Gujarat. And that's how we found that there were 300 patients with hypertension in one village. And the question was what to do. And Dr. Padmini Balagopal, who is from Philadelphia, was living in Karakari for 6 months and did this study. And she called me from India asking me, what do you want to do now? I have 300 people with high blood pressure. And I knew that they are not going to get care. So I said, why don't you call the dean of the medical school? And they sent a van and gave them medicine for about a week. So being a nephrologist, knowing what hypertension can do later in life, I was thinking about what to do with these villages. And that's how I came up with this independent duty corpsman model. But one of the first thing I did in January 2010 was to go to the chief minister of Gujarat, who was Mr. Modi at that time. Now he's the prime minister of India. And it's just the two of us. For 30 minutes, he listened to the Sevak project. At the end of it, he said, do it, that's it. And I said, no, let's get a picture and I'll use that as permit. So this is the picture and that's the permit for the Sevak project. Nothing in writing. But since then, we have expanded the project to Gujarat, in Bihar, Odisha, and Tamil Nadu. Sevaks live in the village, the philosophy behind the Sevak project. One of the thing I mentioned is the hallmark, is that they must live in the village. The reason is they know the people and problems of the village. Locals respond to their own. If I were to go in a village and say, oh, we need to screen you for blood pressure, diabetes, they'll probably throw me out. And blood pressure, diabetes screening is new to them and needs someone to explain and trust. We also collect a lot of data on income, work, type of water, source of cooking fuel, education, chronic disease, vaccinations. Data in this type of program is the key. It tells you what may work, what may not work. I'll show you some data in the slides. We found many new diabetics and hypertensive patients, and they refer to the primary health clinic. Now, just for everybody's information, for every about 7 villages or 30,000 people, there's one primary health clinic. And for every 7 primary health clinics, there's one community health center, which has a doctor, a midwife, and they can do deliveries and all that. Some PHCs have capability to do deliveries. Now, then of course, after that you get district hospital, city hospital. Now, they may not be adequately staffed, but the infrastructure for delivery of healthcare in India is very robust. Again, it's based on the chief minister and the party that rules that state in supplying the necessary equipment and staff. Sevaks have identified special cases, which I'll talk about later on. And in some cases, they even go to the city, taking the patient for referral to major hospital. They know houses without toilets. And one of the things that the Sevaks did is explain to the people why they need toilets in-house. Today, we have, in the Sevak villages, over 85% of the families with in-house toilets. Some have 100%. We have also built 10 reverse osmosis water plants in partnership with Wills Global Foundation. In one village, there were 250 patients out of 1,000 with kidney stones. And once we put that RO plant, today there are only 12 people with kidney stones. In another village, with partnership with Habitat for Humanity and Wills, we built toilets, 110 toilets, to reach over 100%. Now, in another partnership with CETI, which is Collaboration to Eliminate Tuberculosis from India, we have trained all the savers to screen people with active sputum and get them to be screened by PHCs. The next project is, the reason I'm going through all this, it has a lot of bearing on pandemics also. Then in this case, another NGO came and said, would you partner with us to screen girls age 11 to 40-year women for anemia? This is a very important thing, and we found a lot of girls, young girls, with 7 and 8 hemoglobin. So they are started on iron, and we are also looking at fortifying the family food with iron. Breastfeeding training has been conducted by Dr. Padmini and Rupal. This is another important issue about breastfeeding. Now, hopefully, these initiatives will help decrease maternal child morbidity and mortality. Now, we also looked at the role of telemedicine, telehealth, because a lot of people from United States say, oh, you can just put telemedicine and do it. But villages don't have infrastructure. The bandwidth is not there. But some PHCs and CHCs could use this, and large villages. This is it's a camera-like device to screen for anemia. You pull the lower eyelid down and look at the conjunctiva, and that takes the image which compares with stored images and gives you the reading. And there's like this is like an iPhone at the back screen. This is the Sevak, all the Sevaks, since they had downtime, we asked them to take the government course on COVID. And all the Sevaks have this kind of certificate. This is a Sevak from Gujarat. This is a Sevak in Tamil Nadu. The courses by the government are in different regional languages also. Now, COVID has been disastrous for everyone. And question is, how do you prepare for such pandemics? Sevaks have the capability to play a big role in the villages because they know the villagers, and they can explain the villagers and how to comply with the government regulations in masks, separation, hand washing, things like that. Now, cities don't have Sevaks, but they can create a Sevak-like project by region. In the villages, Sevaks work in collaboration with ASHA. ASHAs are accredited social health activists. What these are females, all of them. There are about 900,000 ASHA workers in India. They have about 10 types of medications for fever, diarrhea, malaria, vitamins, things like that. And they also take pregnant women to the hospital and bring them back. They're incentivized by what they see and what they do. If they take a patient for delivery, they probably get 100 rupees or something like that. And Sevaks also work with PHC. Anganwadi workers. Anganwadi is like a nursery, and that keeps, they do babysitting for children up to 5 years and also provide a nutritious meal. And this Sevaks can form this partnership and become very important in COVID. Now, the reason we have success with toilets, blood pressure, fasting, blood sugar is because they've been doing this and toilets. It's easy for them to explain about mask, distance, wash hands. We don't really have to go there. We can just tell them on phone that you need to do this. Now, how do we train them? The reason is these Sevaks come from all walks of life. We have had some laborers, first-year students in college. Some are housewives. And we train them first in anatomy. Basic anatomy includes all the different organs, show them on the actual specimen. And this helps them understand, and they can retain in their mind that I saw the heart and this is the function of the heart and what are the diseases with the heart. So we have anatomy, we have clinical medicine, physiology, and then we have practical. We also have specific diseases like diabetes, hypertension, and all that. Infectious disease, how to save children's lives below the age of 5. Because in India, in the villages, a lot of alternative practitioners are there. For example, in the old days, they'll go to the temple and say that if I pray for, or if I do this particular ceremony, my child will become fine in 5 days. But those 5 days could be very critical in that child's life. And our Sevaks are supposed to tell them that no, as soon as your child gets sick, you take him to PHC. These are all the Sevaks. The person in the back, she's the Maharani, or the mother of the current Maharaja of Baroda. Maharaja Baroda was a big state in the old days, and they still have the tradition of who is the Maharaja. They don't have any political power, but they can influence people. He's the dean of the medical school, and there are some from US. This is last year's Sevak project, all the students. These are some of the Tamil Nadu students, Sevaks. We have some from Odisha, and all these are from Gujarat. He is from Bihar. We had 2 from Bihar also. This is the classroom donated by one of the Wheels health track leaders, IIT alumni. This is the classroom we have. Now this is an anemia chart. The reason we have this chart is when they look at that camera and look at and get a reading of, let's say, 8. On this side, it tells you what should be the approximate reading based on the color of the tongue. This is very pale, this is pink. So they can match it and verify the reading. It's not absolute. This is a hill area, and here is a Sevak doing blood sugar. Another Sevak collecting data. We have given laptops to all the Sevaks. And here's a Sevak giving education to all the women. Another Sevak doing blood work. She's a Sevak in Kutch, which is quite remote. And I think she's the only one we have who is 10th grade. But she's learned how to use the laptop and work. One of the donors gave me money and said, use this for whatever you want, like $100. So I sent it to her and said, buy food, clothes, whatever you need, and give it to people in your area. And that's what she has been doing. Here's another, this is in Tamil Nadu. Another Sevak. Now, when I talked about special cases, here is a man who is 42 years old, electrician, got electrocuted with about 460 volt current. He lost both upper arms and a limb also, lower limb. And this was his toilet. What the Sevak in that village did is he called me and he says, I have this issue, what can I do? So I told him, get a contractor, build a toilet for him, sitting toilet, and we'll fund it. And that's what we funded. This was done within a week. Now, this type of issues keep coming up all the time. Here is another one. This is insulin vial. This is a boy who is insulin dependent diabetic. His blood sugars were like 400, 500. And we realized why, because this insulin has to be kept at 62 degrees. So all the insulin-dependent diabetics that we had in the Sevak villages, without refrigerators, we distributed refrigerators. Now in India, they have not developed a refrigerator for this particular purpose. Here's another Sevak taking. Now this person, excellent student, he runs a kiosk, but he's blind. So he needed money for inventory, and the Sevak project wound up doing that. So we get into these issues, and I think we can almost do anything with the Sevak. Here's a Sevak in another village who runs the RO plant. And this water is distributed, this is a 20-liter bottle for 5 rupees. American Heart Association actually came to Baroda, which is where I showed you the Center for Training. And they gave a talk for a day and a half on how to save children's lives below the age of 5. And this talk went really well. Every year we have a refresher training in this particular issue, because it's, again, as I mentioned, that there is delay in treatment when the child is sick. Now, Wheels has installed the reverse osmosis water plant, and I mentioned about the 5 rupees for 20 liters. 5 rupees comes to 7 cents, US 7 cents for 20 liters. Now, another thing that happened is in the Sevak the female Sevak who was running the RO plant, she told me that in her village, they had drought for many years and women had no jobs. If I could create some jobs for them. So what we did is last June, I was in New Delhi and went to a museum called Sulabh Museum. It's a museum of toilets from ancient time to modern time. And behind that, they had these training centers, various types, including sewing center, beautician's classes, and one room had how to manufacture sanitary napkins. And I asked the person, how much would a plant like this cost? And he said, 400,000 rupees. I shook hands with him and I said, can you deliver this in Mota Kalava Devbhumi Dwarka? Devbhumi Dwarka, and a lot of you may know or have heard of Krishna. Krishna is one of the Indian gods. That is his state. And what I say is that a sanitary napkin factory in the backyard of Krishna's home. So now we employed 10 women there. In Davalgarh, Surendranagar district, another issue was these girls, 13, 14-year-old girls, were just hanging around and asked them, what do you do? Oh, we stay home and don't do anything. They do domestic work and they had to leave school because to go to school, they had to go by public transportation to a village that's 15 kilometers away. And the parents would not let them go in public transportation. So we put a sewing center to teach them how to sew clothes. That way they can make future livelihood. Now we are looking at how to do screening for cancer in these villages. That's a big hurdle also. Women in rural India do not get screened for anything. We have screened over 13,000 girls and women for anemia. This is the sanitary napkin factory. There are different stations. And this is when they received the training from people in New Delhi. This is the sewing center we have. She's the teacher who's teaching all of them how to sew clothes. Now, coming up to, so we have data on 60,000 people, male-female ratios even. Now look at the education. As I mentioned before, that one of the important things is to know what you're dealing with when you try to implement or you want to do some project in a village. Look at the education. 27% of the village, no formal education, 34% elementary, 21 some high school, and only 8% are high school education, 3.4 some college, and 2.5 are college graduates. Postgraduate, 0.74, and vocational. Probably this vocational training has gone up now. And income level, these are the people who are employed for wages. They go to neighboring villages or town. And these are self-employed. When we say self-employed, means they are free laborers. And farmers who own land. And these are homemakers. Now, homemakers also do this, farming, labor. Now, obesity and overweight is not that big a problem. 31% are underweight, as a matter of fact. Now, we have only 4.5% diabetics in the villages, but 2.8% did not know they have diabetes. So by diagnosing them with diabetes and giving them education in diabetes, we are hoping that will prevent complications that may prevent disability in future life and continue to work. 8.5. And these are some of the awards that Api got. These are all the news clippings. We have written some papers on this. And this is the website for the Sevak project. And this second website, I created this because I go from village to village. And a lot of times they ask me for information. And on this village, I have a lot of links by topics, for example, diabetes, hypertension, heart disease, cancer. And they're all linked to government websites and things like that. I haven't invented anything there. And today, we also have information on COVID on that, which is a link to CDC. So since I can remember my name, I don't have to remember all those links. And that's the reason. There's also a book on this website called Indian Foods. It's a guide to diabetes and nutrition. So if anybody wants to look at it. And these are, of course, my favorites. Bina? Think I'm done. I can take questions if we have time. I'm unmuted, I think.
No, I'm not muted. So I think, Dhanraj, do we have any questions from the audience side from YouTube? No. So we have Jayanta, Dr. Jayanta Bhattacharya and Dr. Omkar Mittal have already joined us, and they have, just like you, they have extensive field experiences of working with Indian communities in India, especially in the villages. So if they have any quick comment to give, that will be great. Otherwise, I can invite Dr. Jacob to begin with his presentation.
I just have one quick thing I forgot to mention.
Yeah, sure.
We have this project in Guyana, in 12 villages, Guyana, South America.
Okay.
And we are going to also start a project in Morocco, in Africa. One of the doctors there is interested, so she's planning to come to Gujarat to get the training and implement the project in her own country. And the other one is Burkina Faso in Africa. Wonderful. But we don't have the resources to do that. So we'll wait and see what we can do.
Dr. Patel, I was taking notes and now I have your website and I have all the information. So I'm going to make sure, the information gets delivered where I think they need this project. Thank you very much.
Let me know, and if there's anything I can do to help, I'll be more than happy to help.
Thank you very much. You are really, really kind. And also what I like is you put, all the knowledge about being an MD and the place and everything. Usually, we have all these big theories and coming and NGOs and they don't know what's going on in the place. So I think you combine everything just to know what is needed in the village. So really, really, I'm so glad to be here. Thank you.
It is very easy, Maria, if you want to do it. Find a good doctor who wants to get involved and commit some time, because the time that you need is for training, the 7 days or something like that. And if you can't find it, send them to Baroda. We'll train them and send them back.
Thank you.
Thanks a lot.
Maria, you have a reason to be in India.
Dr. Patel, I'm Dennis Weedman here in Miami.
Yes.
Your presentation was very, very fine, in presenting the magnitude of the various public health social issues that you're addressing. And what's very interesting is that by having very knowledgeable people from the community being trusted and well known in the community for what they're doing, that there's such an engagement, a positive engagement by the community to learn these ways of, a better health. A question I have would be, since there's such an engagement of these health workers in the communities with the COVID-19 right now, are you getting feedback from them that is an issue, or are they continuing to be fully engaged socially with this distancing question we have.
We do get, I get feedback on the COVID issue from these Sevaks. For example, in one village, there was one COVID positive patient that came, young kid. And the Sevak went to the leader of the village, we call them Sarpanch, and said, you have to isolate this person. So what the Sarpanch did is put him in a house on the periphery of the village and said, we'll supply him food out there and not let him come in the village. So that's one. In another village, there were two patients, but they were isolated and sent out. So most of the rural India right now, because of the lockdown, there are not that many cases. I'm afraid that once they open up, and if they don't get screened, they're likely to come into the villages.
That's right.
But the villages that are near the cities probably have more, because people commute back and forth.
That's
All right, thank you.
Beenaji, can I make a small point?
Yes, please. Dr. Omkar Mittal is one of the panelists. He'll be speaking tomorrow. And he also has a grassroots experience of working with indigenous community in Jharkhand. Yes, please, sir. But please be quick because we have another presenter to work on. Yes, Omkar ji, quick.
I can drop it also, but I'll make it just a small point.
Yes,
and
sure.
this whole idea of, it's very impressive presentation now, this whole idea of Sevak to be some kind of catalytic for this entire system of ASHA and ICDS workers. This is something which should be taken by Ayushman's team, because despite all the great ideas in Ayushman's team, it is not really working. So have you proposed to Government of India to look at your model, Mr. Patel?
No, I've not got the government involved because, your prime minister, for example, is not a big advocate of government taking over anything. He knows that they fail usually. And that's the reason he gave me permission. He didn't send me to a commissioner of health or health minister when I went to get his permission. He just said, do it. Because he knew the minute he sends me to the government, I'm going to be flying back to US. Because, once you get into bureaucratic jargon, you're done. But eventually, I'm hoping.
Okay.
Sure.
Thank you.
Thank you, Dr. Patel. It was a wonderful session with wonderful presentation with quick discussion as well. We will resume with all.
Got us here today, understanding the concept of healing through emotions, feelings, music, and things like that. And I asked Dr. Bena if I could play a guitar for us for like a few short minutes to kind of like get us into a space, because a lot of what we'll talk about is like things that are like really struggling and hard and hurtful. And this is my way of praying is by, I play a little guitar. And so if you can do your own way of praying or feeling or whatever you want to do while I do this, and I'll do it real quick, So again, that's just my way of kind of like reaching out and feeling that hopefully we feel connected, because that's a big importance. Indigenous people are connect, and we want to reach out and be social, and it's hard, but through our spirits, we should be able to all connect and see. And so seeing your beautiful faces today is a good feeling for me. And also, one thing that we do as Indigenous peoples is that we do this land acknowledgement. And so for me, I'm in Tulsa, Oklahoma. And so this is now a reservation. I don't know if you guys have been keeping up with American news, but our Supreme Court made Tulsa, Oklahoma a reservation. So that's been like a big thing for us. And so here's kind of my land acknowledgement, presenting to you from the traditional ancestral lands of the Osage Nation, the Cherokee Nation, and the Creek Nation. The process of knowing and acknowledging the land we stand on is a way of honoring and expressing gratitude for the ancestral Muskogee Creek people who were on this land before us. All right, so this is going to be kind of like a lot of information. I'm going to skip through a lot because, I was told about 30 to 40 minutes we'd be doing this. I was like, well, I better make sure I have it padded. But then all of a sudden I'm like, oh my God, I got like 80 slides. So, so one thing and then I was limited to 20th century, and I was like, well, I don't know if we can really do 20th century because, again, in our indigenized way of seeing things, we see past, present, and future all in one kind of thing is how we live. And so when I talked to Stephen Fadden, one of my mentors, and he informed me that the effects of cultural trauma that tribes who survived the pandemics of the 16th through the 20th century is still observable and right to today. So we're kind of going to have to go to the 20th century, and then we'll look at what's going on right now and try to do it all within our time frame. So in mid-March, at the beginning of the outbreak, Seattle, Washington was hit the hardest. And the Seattle Indian Health Board had asked the government for medical supplies. And instead of getting PPE, what they got were body bags. And this was shocking. And even though the body bags were a mistake, they were accidentally delivered by their distributor, which was Kings County's Public Health Department. Abigail Echohawk, the Health Board's Chief Research Officer, said that she believes that this message sends, even unintentional, the pointing out of how a lack of adequate resources and funding as promised. And in a way, she was saying this is a metaphor for what's happening. So when we were eventually distributed billions of dollars of pandemic relief fund, but the money went through a lot of delays and went through a month of related legal disputes. And pandemics, have various levels, as you know, from endemic, which is our baseline of where we understand our level of diseases, our baseline with endemics, and we go through sporadic, endemic, hyperendemic, epidemic to outbreak. And then we go to pandemic. And a lot of people, if you have friends on Facebook who send crazy stuff, they're always like, saying, this is just like the common flu, or this is just like fill in the blank. But I say, yeah, but there's a reason why it's called a pandemic, And so pandemics, refers to an epidemic that has spread over several centuries or continents, usually affecting a large number of people, and the impact is worldwide. So the way it's also seen is that as cities get larger, our trade routes grow and our increasing contact with variable populations of people, trade of animals, and change of ecosystem, it is more likely for a pandemic to occur. So brief history of pandemics is like, we have like religious texts and old written stories of plagues that have come, such as lice, disease, livestock, death of children, and they didn't really have names per se as we call them now, but they were similar to infectious diseases, zoonoses, and parasitosis. But the first real, quote unquote, time that a plague was actually written or understood was the Athenian plague. And then we talked about Antonine plague, the Justinian plague, and the more common, the one that most people know is the bubonic plague, which was known as Black Death. And then in 1918, we had the influenza pandemic. And in the 1950s, we had the Asian flu. In the 60s, brought the Hong Kong flu. In 1981, we had the issues of HIV and AIDS. And SARS came in 2000, and the Ebola. And then MERS was around the same time of the Ebola virus. And today we're dealing with COVID-19. So another thing about pandemics is that a lot of indigenous people see colonialism as a form of a pandemic in a way because it's spread across the country and affects a large number of people. And it's also can be infectious in that it puts itself into all world. Like for me, for instance, I'm living in a house that's made from, Western society mindsets of how a house should be built, as opposed to where I would live in a house made of mud and thatch and wood. I'm living in brick. So those are the kind of things that we kind of think of and we perceive as, how colonialism works. So, and then, of course, there was real epidemic/pandemics that happened. And so, and when, in 1492, of course, when we had the first contact with Europeans, the Taino had met him and, they did some trade, they hung out, the Europeans built like a nearby township on Hispaniola. And during that time, because we were not immune to diseases, that we were starting to get sick. And our high population, which some estimate about 8 million, dropped down to approximately 500. And so then 1520 and onward, and that spread out through Mexico and South America. And it's reported that it was infected by an African slave, and however you want to perceive that. And approximately about 50,000 to 300,000 died. And it went as far up the Missouri River, where the Blackfoot tribe was hit the hardest. And so then, you had the smallpox plague that wiped out about 3/5 of the Mohawk population in the Northeast. And it prompted the tribes to raid, get captives, and adopt the white people, because the white people didn't die from the plague. So they, and these white people helped take care of them. But in addition to that, many were kind of forced to become Christians after the Black robes told them that they were being punished for their spiritual belief. So the pandemics affected the beliefs and economies, and much more with the reverberation of modern time. And so as the pandemics continued, colonization continues. We continue going into the Amazon, where they used trees to produce rubber, enslaved indigenous people, and many had fled. Highways and telegraph lines were developed in rainforests that impacted isolated tribes. And even Brazil, they would lay out like we're in hiding to come out and try to get them, and they would catch them and basically put them to work. And so through all these contacts, there was spread and transmissions of diseases. And it wasn't until 1988 that Brazil enacted a no contact policy to stop these attraction fronts and stop from getting these tribes. And again, these tribes were hiding out and not being susceptible to diseases. And so as this continued to process peoples, and their population is about 35,000, and they were nearly wiped out in the 1950s and 60s. And then again in 1987 and 1990, malaria, mercury poison, malnutrition, and violence affected them. And because colonial settlers were out there. And then as recent, a 15-year-old boy died of COVID-19. So that was a third death of the indigenous peoples. And so that raises the fears of how it will impact his tribe. 5 tribes, approximately 900,000 indigenous people, and the reserve of the Amazon. And the largest tribe is around 51,000 people, and the smallest is, as far as we know, 1 man. And so, as you can see, the continuing colonization process, these epidemics play a role in reshaping society and culture as a result of colonization. So in a way, you could say it's kind of a comorbidity that's happening also. And so, so populations of the indigenous people on Turtle Island pre-invasion were about 60 million, which is about 10% worldwide. And due to the diseases, warfare, slavery, and genocide, they killed about 90% of our people. And so this reduced us to about 5 to 6 million in the post-colonization. And what also happened, according to one study, and because the indigenous people had experienced, because of the loss, the carbon dioxide was lessened, and the planet had a cooling down period. And so one estimate was that about 56 million hectares were used for agriculture, which is about the size of France. And so one of the, so once the indigenous people were being killed off, the land was in disuse and the farms were neglected. And also, there's also, the impact of deforestation, which causes more environmental damage. And it would and the other thing about deforestation is that we're destroying the home of animals who care. These homes are destroyed. What are they going to do? They're going to come live closer to us, the human society. And that's another way in which our infections come in through. And so what we know is that historically, a lot of indigenous peoples practiced the eco-knowledge and understood the need to maintain and keep balance with the environment. So this health impact that happened from colonialism was also about losing our traditional medicine, healing practices and our medicine laws. And not only that, but our cultures were lost, and our societies were affected. Language loss means that our language are not used to pass down to teach our next generation of people these healing practices, these healing understandings. And so that also affected us. And even as simple like tobacco or something, we saw it as a medicine. And some of us even had names for them to say, this is a medicine that cures that. And so now we're not having that because of this colonization problem. And then one thing that brought to me was that pandemics are even weaponized. And so when Jeffrey Amherst sent a letter to Colonel Henry K in 1763, he said, do not be contrived to disaffected tribes of Indians. You would do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate this execrable race. So basically, he had this idea of using smallpox to destroy us in a weaponized way. And there's a debate on whether he used it or not, but we do know that there's at least evidence that two infect blankets and one infected handkerchief was given to Indians. Whether that was purposeful or not, we don't know. But we know how Americans tend to hide our history of how we treat other people. And so for me, I'm Choctaw. And so what happened with us is that Europeans came with animals and they were regularly infected. Miguel de Narvaez was the first European to invade our Choctaw country in 1528. We fought and we forced them back out of our land, but there were survivors and we took in the survivors to help heal them back and take care of them. But what we didn't know is that they were infected with a fever, and that killed about half our community. And once again, 66 to 90% of our population were affected by this disease. And so we had to figure out how to deal with these diseases. So before, we were peoples who lived closer to the rivers, but when the Europeans come in, we noticed that the spread of diseases were on the rivers because that's where they would do their trade and they would travel up and down the river. And so we had to move more inland in order to protect our peoples from getting sick. And now in the 20th century, of course, the big pandemic we talk about is the influenza pandemic, which was an H1N1 virus with genes of avian origins. No one knows exactly where it came from, and it hit us in 3 waves. And so what happened was, like with American Indians and Alaskan Natives, there were tens of millions who died from this in 1918 because of, again, colonization put us in boarding schools. and took us away from our homes. And in these boarding schools, we were in close proximities that we started having the effect on each other. And some communities lost almost all of their residents. And then in our villages, when one gets sick, many would get sick. And so like with the Inupiat village in Alaska, 72 of the 80 Inupiat residents died of the Spanish influenza in 5 days. And so what happened was the territorial governments sent gold miners from Nome to dig a grave for the victims. And so this flu spread rapidly in institutions settings, including government-operated Indian schools and so on. And so then there's some information about how it affected us as Indigenous peoples. One real famous one was a letter that Lieutenant Van Wert wrote, and she was in Washington, D.C., and she was writing to her friend who was at Haskell Institute in Kansas. And Haskell Institute is an Indian boarding school. And so the reason why it's so famous is because she kind of used, humor to help alleviate this pain that she was feeling, because she was volunteering in Washington, D.C. with the soldiers who had gotten the disease. And so one of the things she would say is like, so everybody has the flu at Haskell. How's Miss Keck and Mrs. McKay? Hope they would get it and die, because that would be good riddance, not much of a loss either. So, she's very, dark humor kind of. And so one of the theories is that the influenza started in Kansas, and so that's close to where Haskell Indian Nations or Haskell Institute is, and people are, people again within boarding schools getting sick, getting disease amongst each other. And so Lieutenant, she, like I said, she volunteered to work with soldiers and, gave medicine, took temperatures, gave them ice pack, rubbed their legs and all their back and all that. And so what happened at Haskell, because they had a newspaper, so you can go back and look into archives and find their newspapers, that they showed that the first report was in April 1918 in Haskell County, Kansas. And on March 17 is actually enough to require day and night attention. And so for us, the Choctaw, the influence affected us is that it was considered one of the worst natural disasters in human history for us. But we kind of remembered how we were affected when the colonial settlers first came in. And so we had a sense of resiliency, that we knew that we had to be apart but together. And so family and communities would care for each other and provide food and all that, and even bring in kids whose parents or family had died. And so what happened is by October, 4,191 people had contracted in in about 24 counties. And by this date, there were at least 291 deaths, and 100 in Pushmataha County and 250 in Antlers. So that's all in the Choctaw Nation. And about 7,500 people across the state by the spring of 1919 in Oklahoma. And so what they found was that it was not any particular medicine that helped the survival, but rather was simply being there for someone. And so they would take care of each other by bringing blankets or giving lemon juice was one thing that they did to help alleviate. And so they also rebuilt the community after all of it. And again, we talk about the cultural loss. And so then we got COVID-19, where again, the Choctaw Nation is highly affected. We have about 55.2% cases on our actual reservation in Mississippi, which is the majority of the people affected, and about 65.9% death within that county in Mississippi. And where I'm from, in March 23rd, we started at 0 cases, and now we're about 46,893 cases with 644 deaths. And the unfortunate thing for me is that I'm at a point where I can't even count on my fingers how many people have died. So I know close enough more than 10 people who have died from it. So, you know, again, I kind of get upset whenever people post that. It's just like a common cold. So I don't know that many people dying from cold. So anyways, and so Navajo was also one of the tribes that were very heavily affected. About 22% of theirs tested positive, and that was a percent that's higher than what was going on in New York City percentage-wise. And so our indigenous responses have been that we have had challenges that have affected from this because we're multi-generational households. So we live as a big family in one house. And so once somebody gets a good size of people would get it. So, you know, you could have up to 10 people living in one household. And so also we're social people. And so visiting and social interactions have been affected. And even in our ceremonies, which are all social ceremonies, we have had challenges with those. And then with multiple health facilities, there can be issues of coordination between hospitals, Indian hospitals, and what they call the 638 facilities, which is the funding that that the Bureau of Indian Affairs and Health do, is that they fund, you know, where you can go to different doctors, specific doctors. And so if all three are used by a single person, the difficulty is in care and coordination through the hospitals, Indian hospitals, and the 638 facilities. And then there are those beliefs of like this getting the illness is because you're not living right, and that's why you got it. And so when somebody thinks they're living, you know, they're living a good way, they're probably less taking care of themselves and putting others at risk. And the other beliefs are like when someone dies at a hospital, someone won't go to that hospital because they fear that the energy is still there. Or even if someone's sick at a place, like at a school, someone won't still send their students to the school because that energy of that disease is still there. And also there's government distrust because of our past relationships with the government. So, you know, how do we know that this is another way that they're trying to obliterate us? And there was also with the Navajo, there was discrimination because of their high COVID, and so hate and racism happened as a result of that. And so some of the things that was talked about with the people I interviewed was that that our health is affected from colonization. So we have diabetes, heart disease, high rates of obesity. And so it's not just about using medicine to treat these risks, but also to get us back into our traditional eating and paying attention to what we eat. And the microbiome is important. And so eating fermented foods will help. And so one of the things is like, you know, getting back to traditional foods, because what someone said was like, you know, we had over 300 varieties of food that we would eat traditionally back in the day, but now we probably eat about 50 different types of foods. And so perhaps we need to get back to that balance and that diversity in our food systems. And so there were a lot of great responses in how people handled this recent pandemic. Muckleshoots were quick to shut down schools, get everybody home. Their traditional food is seafood. And so when there was a tribal member who had low access to seafood, they would get the seafood out to them. And so with San Carlos Apache, it was a tribal managed hospital. And so they reacted quickly. They did everything to get money for supplies, and it accelerated the equipment needed. And when their casinos shut down, the tribes chose to secure rooms in the hotels of the casino as a way for community members to quarantine, where the hospitals paid with emergency money. And due to these proactive approaches, the numbers have gone down. And the other good thing that there's a state to tribe relationship in Arizona, so that when the Navajo decided to quarantine the whole reservation and not let anyone that isn't a member in, the leaders of Arizona said that was a good thing. And so let's see here. And basically other indigenous people are doing things like the Peruvians created a guideline called a safety protocol in our native communities, a guide for native communities in the San Martin region of the internal management of COVID-19. And they did this on May 13, long before any government tried to do some kind of intervention with them. And so some of the responses of resilience is that, you know, we have been using our traditional knowledges and practices to find solutions to pandemic problems. And so we need to gain those back and look at those. And so like the other thing is like, again, it's that community aspect where tribes in Brazil would make food to deliver to students or kids who didn't have it. And in Colombia, they mitigated restriction on movement by organizations, the distribution of their harvest based on families' exact location. So they located where people were and figured out how to best get them their harvest and food. And so then some of the things is that we talked about was that because of that history of our treatment by the colonizers is that many of our traditions have been lost because they vilified traditional practices. Like when the plague would come, the traditional healings are affected and the risk not being practiced. And during this pandemic, all healing practices are needed. And also they talked about plants, traditional food and nutrition are ways of protecting our immunity. And what we learned from our ancestors is the way that we could thrive and survive. And so basically, we also talked about how indigenous peoples, we need to have our words listened to. We need to be heard because even though we may not have the doctor in front of our name, we are community-based scientists. And here in the United States, we were the first scientists. And what our science was observational science. And we understood how relationships work and how things work. And from, you know, the very beginning, from the universe to plants, and that strong power of observation saw these things and knew how the knowledge of the plants and herbs and what was good and bad. And so the other thing that I was told is that, you know, we even had a way of connecting with the animals and the rocks and the plants and everything, and it would speak to us. I don't know if that was literally or a way that we can listen, but perhaps it was both. And those kind of things are lost now. And so now, you know, what's great is that we have our even though our traditional practices of ceremony, which are healing practices, my biggest concern was that we would be losing that because a lot of them have been canceled because these are all social events. But what happened is they used health guidelines, kept everything outside, got together and did a lot of our healing ceremonies. The green corn ceremony went on. The Yaqui are still doing some of their ceremonies. Other tribes are doing, and we probably don't even know to the extent because they're keeping it, again, hidden, just like they did from the colonizers, because we have to keep these moving on, keep our people healthy and keep our people good. And so my basic takeaways in learning all this and talking with my friends about this is that the resilience is strong in our indigenous peoples, and our need to thrive and survive is important and acknowledged. And one of the biggest things that was talked about was regaining traditions and relearning how we use our medicines, relearning how we use our language to understand how these medicines work, and how community is important. And this is like a community affected disease, but still, even with that, we know that we can do something for someone, even if we can't be there for them, much like we are here like this, we can feel this emotion and these feelings of love and joy. And one of the biggest takeaways was like, one of the Muckleshoot worried about doing their cultural teaching classes with children. And what they said is, we're just going to do it outside with social distancing, because in reality, if this was back in the day, we'd all be outside learning this. And so they go out there and none of the children have yet shown any signs of illnesses. So being outside is probably an important thing, and being in our natural places. And so Yaqui peoples told Dr. John Molina that every disease and illness is trying to tell us something, to ourselves and to our people. And what it is that we need to get connected more spiritually. And as a physician, he believes that strong connection between the spiritual and the physical is what we need to think about. And when Indigenous peoples have a strong physical life, that's when we do our best. And so he thinks that balancing our spiritual and our physical is what we need to think about, and to listen to what these illnesses are telling us, listen to what the earth is telling us. And the other big question that we don't really have an answer yet, but it's something that we need to think about is for the future. So we knew what happened in the past. We know what's happening now. What are we doing to prepare for that next pandemic? Yako Key, I see you, I hear you, I feel you, acknowledge you, and I love you. Yako Key.
Thanks a lot. I would say dhanyawad. I would say बहुत shukriya. Yeah, because it was really great and very insightfully you have brought out not only in the historical context, but also what are the contemporary challenges which the pandemic is giving to us. Because we have little time, so I would request Professor Wiedmann now to give his quick comments, and then we will proceed for the third presenter. And Dr. Jacob, we will take all the questions and discussion points at the end of all the 4 presentations. So right now I'll invite Professor Wiedmann to give his quick comments, say if he has any.
Oh, hello. Good. Tvli, that was very fine. That historical view from Native perspective, and I appreciate that you grounded your presentation by speaking to others, other elders, other people from other parts of the communities in the country. So that brings to our seminar today a much broader Indigenous voice that is very, very important. And so I appreciate that. I appreciate the work you did to make this very meaningful for people of the world. I really do like the way that you were able to express the especially right there at the end, the balance, the connectedness between the physical and the spiritual and the community, making sure that the children have proper learnings during these COVID times, and the way that you did. You must have talked about a dozen different tribal groups from the Inupiat all the way down to the Mississippi Choctaw, and so very impressive for all our audience to know and to hear that directly from you. So I thank you for that. When it comes to the COVID, I can see that, and from yesterday's talk too, we heard that the communities were re-engaging with their medicines and their language and resilience, and so that seems to be a common thread here. And so the history that you provided with the many epidemics over time, since Columbus and the Taino, all the way up to the present, that our audience needed to hear that. Thank you very much.
Thank you. Appreciate it.
I'm just unmuting myself. Yeah, thank you, Dr. Wiedmann. Do we have any other comment, quick comment, if we have Maria, MLV, Dr. Jean, or Dr. Patel? Because we have just fresh ideas right now. Otherwise, I'll proceed with Dr. Jean. Dr. Jacob, please be with us. And so we will be having definitely lots of questions. So now I invite Professor Jean Tinnie, who is actually working on a various platform on Black history research. My first introduction to Dr. Tinnie was because of Black History Research Center, which he is actually developing in Miami, USA. So I'll, for the audience and also for all of us, a short bio I'm going to read about Dr. Jean. Professor Dinisulo Jean Tinnie is a well-known visual artist, retired educator, writer, and independent researcher. He's also co-director of Middle Passage Ship Replica Project. Dr. Jean Tinnie, a New York-born, Miami-based visual artist and designer, writer, retired educator, and an activist, is in historical preservation and cultural affairs. With an academic background in the study of foreign languages, literature, and linguistics, earning graduate university degrees from France and the United States as a Fulbright scholar, he is founder and co-director of a slave ship replication project and serves as a board of trustee related to the restoration and preservation of historical and natural landmarks related to the indigenous and African North American history and heritage. His artworks have been widely collected and exhibited, including several public art commissions, and his writings and commemoratives have frequently appeared in South Florida newspapers and scholarly publications, including Venerable Journal of African American History. He is the recipient of numerous prestigious awards and recognitions for his diverse community service. Today with us, he is going to present The Future is Now, Africa, Indigenous North American Perspectives on Proactively Creating a More Harmonious Post-Pandemic Society. So I welcome Dr. Tinnie, Professor Tinnie, to please share his thoughts with us.
Thank you so much, Bina, and to the whole team that organized this really meaningful, necessary seminar. And I want to naturally give thanks to the two presenters before me. It's kind of hard to follow. I don't have that kind of medical expertise, and I don't have a guitar and that kind of skill either. But much appreciated. And also, I definitely want to say special appreciation also to the presenters yesterday, Dr. Maria Luisa Beisaga and Dr. Reyes Contreras, for their insights. So much thanks. And I guess, you know, as the saying goes, the best way, the most effective way to give thanks is to make the most effective use of the opportunity, which I'll humbly try to do. I'm going to, at the risk of curing your insomnia, if you have that, I'm going to try and read this because there are, or the most of this, because there are so many points, and this way I can kind of pretend to be a better speaker than I am. So, excuse me. So let's start off here. So in these curious and challenging times of fabricated notions of fake news, fraudulent claims of voter fraud, and the foisting upon the public of so-called alternate facts as being worthy of consideration, even as a pandemic ravages the globe, demanding only the most honest and straightforward assessments and action, an appropriate place to begin this presentation from North America, or Turtle Island, might be an African-American folktale, which tells how one day truth and lie agreed to go swimming together. Reaching the water, truth undressed and jumped in, whereupon lie picked up the clothes. Oh, excuse me. Oh. Should have had my phone off, I'm sorry. Whereupon lie picked up the clothes, put them on, and has walked around ever since claiming to be truth. So where does that leave us? So individually and collectively, we're on our own to know the difference between truth and lie. So how can we? I mean, after all, lie cannot be accused of anything other than being truthfully what lie is, and even comforts us with the appearance of truth, while we can ill afford to have our delicate sensibilities so shocked, offended, and outraged by the stark nakedness of truth that we dare not see it for what it is. As we, excuse me, as we seek to make meaningful, life-giving, and life-sustaining contributions to the present response to the pandemic, cross-cultural experiences are certainly most relevant, both from the past, being instructive as to how we have come to this point, and in the present, which most importantly, I would add, that the title of this presentation suggests that the present informs the future, and indigeneity has a critical role to play in this. So without being overly simplistic or stereotypical in our assessment, we can fairly say that we have come to where we are as a human species as a result of two sets of cross-cultural experiences, one in the past with invaders, colonizers, and settlers, pervaded by the overwhelming madness of lies, and one in the present necessarily with the indigenous presence, informed by a quest for truth, which arguably has no other reason than to shape the future accordingly. So indeed, the title of this presentation is, as Bina said, the future is now, African indigenous North American perspectives on proactively creating a more harmonious post-pandemic society. And this title is based on the proverbial observation that the past is present, the future is now, with its corollary that the only time that actually exists is the present moment. And of course, we're all familiar with George Santayana's famous phrase that those who ignore the past are condemned to relive it, or our more common proverb that, in order to know where we are going, we have to know where we've been. So kind of a subtext of this whole presentation will be this juxtaposition of reactive and proactive, and of truth and lie, and of past, present, and future. So for the specific purposes of this presentation, cross-cultural experiences in the title will refer to Native and African descendant experiences, both separate and conjoined, in the geographic setting of the continent of North America. It is not accidental that my fellow panelist, Dr. Jacob, and I represent the American states of Oklahoma and Florida, respectively, two of the locations where these two parallel narratives have been most closely unified by common purpose and destiny, fully recognizing the numerous fully integrated Black Indians, quote, tribes that exist. I'll be coming back to that as well. Basically, where we'll go from here, just to kind of give you an idea of how I'll be shaping this, so look at three areas: language, land, and essentially the future. What should this proactive response be, having drawn the lessons that we can from language and our relationship to the land? The language we speak, the language we use, shapes the thoughts we have, and therefore the decisions we make and the actions we take. Language, as professional linguists would remind us, is a neutral and universal human phenomenon consisting of sequences of speech sounds, which may be analyzed as sentences comprised of phonemes, morphemes, and lexemes, that is, sounds, syntax, and meaning, which all humans, barring exceptional factors, inherit innately as an ability to speak first language or a mother tongue is just part of our genetic makeup. Part of that scientific approach to language is the recognition that no language is inherently superior or inferior or more advanced or less scientific or logical than any other. As such, this scientific understanding of language, free of subjective or unfounded judgments, becomes a metaphor for the anthropological principle of cultural relativism, whereby all cultures are recognized as being similarly created equal, as manifestations of any given human group's historical experiences, aspirations, values, which in turn becomes vitally relevant to this discussion. This is precisely because language in the real world only exists in actual social, historical, and cultural contexts, reflecting beliefs, emotions, and agendas as to how to survive and thrive in the universe. With that in mind, we might consider the following 4 factors as being ultimately relevant to our own proactive agenda for the creation of a healthier post-pandemic world than a healthier post-pandemic world than the pre-pandemic realities which have contributed to the present crisis. First, we can hardly ignore or consider as irrelevant that these proceedings are being conducted in the English language, whose extent of global influence is nothing less than remarkable. It is the lingua franca of the air traffic control industry, for example. And as of 1987, more than 3 decades ago, as the human population numbers continue to continue their rapid increase, non-native speakers of the language have outnumbered statistically the native speakers, setting the language on interesting evolutionary trajectories far beyond the Queen's English might recognize. Of course, this widespread presence is not by happenstance, but the result of an historical agenda of empire, invasion, conquest, and colonization, such that the world today, with its present political boundaries, can only count 22 countries which have not been invaded by the British Empire. It is this reality that gave rise to the very need for such terms as indigenous and indigeneity in the first place. That fact, too, becomes directly relevant to the second general consideration of the role of language, which is that the practical use of English and other Western languages, be it noted, in the real world that we know, also embodies cultural biases and presumptions that are built into its usage and application to actual circumstances, as in the formulation of scientific and legal discourse, not to mention popular culture. Suffice it to say, at the risk of grossly generalizing, that the English language embodies at least the following 4 presumptions, built in as it were, and largely unquestioned. A, the humanist cultural heritage rooted in ancient Athens, which posits that man, in quotes, is a separate entity from the rest of the physical universe, who has the intellectual capacity to analyze it, figure it out, what it's made of, what makes it tick, and therefore, as a superior being, man can exercise a measure of management and control over it. This analysis most significantly requires the creation of categories with verbal names, in other words, language. B, the language is also heir to the monotheistic religion and cultural tradition, which implies that some cultures have the only true and valid scientific beliefs, and even the only true and valid language for that matter, just as they alone embody the only knowledge of the true God. C, these cultural presumptions give a high degree of primacy to the word as the only recognizable embodiment of knowledge, or to put it differently, recognizes knowledge as something that happens, quote, only from the neck up. And D, the primacy of the word also creates a concomitant primacy ascribed to literacy with 2 notable characteristics of its own, one cultural and one psychological, so to speak. The cultural one is that the revolutionary invention of the printing press changed to verbal communication from collective and oral, as in the recitation of epics by traveling bards, to private and individual, ultimately yielding that stereotypical image of the English traveler being carried on the back of a native through some faraway conquered jungle whilst reading a book, oblivious to the surrounding country or having any importance or relevance. And the psychological part would be that the ability to associate a linear sequence of visual symbols on a page with an oral sequence of speech sounds unfolding in time is not a universal psychological experience. Although it may be widespread through many languages, it does not comprise the only definition of literacy or reading. And here I'll just throw in a kind of a small anecdote. This was in the late 60s. I had lived out of the country for 2 years. When I returned, there was a lot of buzz about a television production that had gone on maybe a couple months before, where a group went to Uganda, and they were exploring the effect of learning to read phonetically on the culture. And what they found was that the people who had not been exposed to that form of literacy were able to perceive the world in different ways, so that for them, a game of checkers would last about 40 seconds, as opposed to what we're used to. That was, I don't know if you heard that, that was a thunderclap, so I don't know if that's how to interpret that. Here again, what we want to do, we want to make sure that we separate out those factors which are arbitrary and cultural from those which can be interpreted as universal. Thirdly, and we're back to our 4 considerations of language, it is equally, if not more important, to recognize that the indigenous populations who had English and other colonizers' languages and cultural biases imposed on them in their own lands were not merely passive victims of such oppression as their oppressors might have wished, but had their own reactive and proactive adaptations to the new situation. This included creating their own creolized versions of the foreigner's language, which paradoxically could become a unifying vernacular among different indigenous groups who might not have otherwise had a lingua franca to bring them together. Even more importantly in that regard, responses to the foreign language might often include a total embrace of its most correct form, the Queen's English, so to speak, and using it even more eloquently and purposefully than the colonizers themselves, in much the same way that colonized peoples have often accepted religions brought to them by missionaries and given those religions, those belief systems, even more fervor and spirituality and genuine spirituality than the proselytizers might have imagined possible. That pattern extends, of course, to the full panoply of indigenous appropriations, adaptations, cultural retentions, and reinventions regarding the interface of traditional cultural exigencies with cultural imports from the colonizers. We might consider, for example, the Inuit people of Canada's adoption of the snowmobile to replace the dog sled, or one that I've frequently cited, the African-American appropriation of the basketball or the saxophone to produce things that the inventors would never have imagined possible. I might mention in this case too, one of these appropriations is of this whole concept of indigeneity itself. As you'll see, the word, the coining of the term is a result of a colonizing agenda. Certainly not to be overlooked in this scenario are 2 particularly notable factors that inform the future in present time. A, the appropriation by indigenous groups who, as Dr. Reyes-Contreras pointed out yesterday, call themselves by their own names. The appropriation of that's what I just mentioned, the concept of indigeneity as a unifying force and as a platform for negotiations with the colonizers. And B, the indigenous awareness that the word this idea of knowledge only being from the neck up is not the full definition of what can comprises knowledge. So this is to suggest that that indigeneity recognizes that huge component of what we would call knowledge of the universe, our connections to it, is certainly nonverbal. Our discussion will return to those points. Now, there's a fourth consideration, which is a kind of an aside, but it's worth mentioning. And this is a brief tribute to the late historian and scholar from Guinea, West Africa, Ibrahima Babakake, who dedicated much of his professional life to this whole concept of popularizing academic knowledge and discourse. He, as a matter of fact, ironically, paradoxically, he died on his way to a conference. He was living in Paris. He died at the airport on his way to Africa, back to Africa after decades, to participate in the launching conference of the UNESCO Slave Route Project, which is a project that calls on all of the nations, all of the locations around the world that were touched by this whole human trafficking that's commonly called the slave trade. It wasn't a legitimate trade, and the people were not slaves, they were human beings. But here again, this is how language can operate. At that launch conference, his paper got to be read posthumously after it opened with a moment of silence in his memory. And what it was calling for was, or asking the group to recognize, is that the knowledge that we share in conferences like this one should not just be restricted to university campuses or nice hotels or genteel conferences. This should be knowledge that taxi drivers, dock workers, domestic workers, everybody should have this as their birthright and their household knowledge, as we say. So we ourselves might consider, after this conference, are there ways to, couch a lot of this discussion in ways that that reach people in ways that enhance their lives. And with that, I'm thinking back to Dr. Patel's earlier presentation, where this kind of knowledge was actually shared as in the form of action, and notably in Guyana, my father's homeland. So yes, special thanks for that. So those general observations serve the backdrop for examining, I would say, one particular term, which is this whole term of the so-called New World, which is being represented. Let me catch up to where I was. Okay, yeah, here we are. Obviously, the most striking aspect of this term is its blatant Eurocentricity. I mean, to whom is this other half of the world new? This is the same rhetorical conceit that we witness when we hear news items that announce the discovery by scientists of a new species of deep sea fish, for example, as if it never existed before a special group of individuals noticed that it was there. Yet this patent absurdity is reported as if it were a logical truth. As such, this revealing terminology is symptomatic of an extremely important and a larger phenomenon that might be called settler discourse, which applies to any number of settler nations, which are, and notably, these settler nations are not of any particular ethnicity, not exclusively European. We might cite, for example, Australia, Brazil, Canada, Israel, Liberia, South Africa, Taiwan, New Zealand, among others. And certainly all of those recognized modern nations, which comprise the quote unquote New World, with their political boundaries, flags, official languages, currency, etc. Settler discourse consists of the standard tropes that practically all settler states share, established by invaders with with relatively minor variations in form and degree. These are pretty much familiar. And just to put it in context, all of this is aimed at what will inform how we create a post-pandemic, healthier, more harmonious society than the one that preceded the pandemic. So, among these familiar tropes, the history of the country begins with the settlers' arrival. All else is either, quote, prehistoric, and thus dead and irrelevant, or non-existent, as in the numerous settler origin myths that the lands that they invade were uninhabited. Secondly, naturally, such indigenous people as the colonizers might encounter are in short order made to be foreigners in their own land, who exist at the whim of the settlers, either as a resource to be exploited, such as laborers or consumers, or to be removed as a nuisance by either displacement to unwanted territory or by extermination. The settlers' arrival and conquest is sometimes always sanctioned by some higher divine authority whose will must be obeyed and served. Indeed, the doctrine of discovery, famously or infamously sanctioned by Roman Catholic popes, provided just such spiritual cover, even beyond the realm of the Catholic Church, so that, for example, glorified English pirate Francis Drake could baldly pronounce regarding the indigenous peoples he encountered in his explorations that their gain shall be the knowledge of our faith, and ours shall be such wealth as their country hath. Fair deal, right? The delusional rhetoric of discovery, so-called, is only the beginning of the absurdity of settler discourse in which contradictions and even outright lies are normalized as truth. Perpetual warfare against indigenous peoples is called pacification. Wanton, unprovoked massacres of native people is called the defense. The barbarity of slavery and the regimen of unrelenting violence that is the only means of imposing and enforcing such an unnatural social order of unearned settler supremacy is called the, quote, civilizing of savages. The next one is the settler state is above judgment and reproach by the outside world, which is scandalized by such rampant injustice. They cannot judge us. They have no idea what we have to go through to be secure, is the settler's cry of defense. Indeed, the mental defense mechanism that psychologists call projection is essential to settler discourse. They think that we think like they think, we often observe. They're convinced that given the chance, we, the colonized, would act as they do. Hence, such current day allegations that the Black Lives Matter movement is an attempt to establish Black supremacy and therefore a terrorist organization of wannabe exterminators of so-called white people. All of these elements of settler discourse are embodied in the term New World when it is used as such. It is so seminal to the foundation of modern settler nations that educational institutions might rightfully be indicted for criminal neglect and fraud for not studying this phenomenon, especially in such disciplines as anthropology, sociology, and psychology. One might rightly ask, what is more important to study? Interestingly and significantly, some beginnings of such a study can be found in the work of the late famed Martinican-born French psychiatrist, Frantz Fanon, but his observations tend to be secondary and ancillary to his primary focus on the minds of the colonized. Nonetheless, this initial foray was prescient as we witness a growing interest today in addressing racism and its consequences, such as unpunished lynchings, as a mental health and public health issue of delusional, dysfunctional, and sociopathic behavior, more so than simply as a political issue, which could be addressed as with rational discourse and resolution. As such, in relation to the task of creating a harmonious and mentally healthier post-pandemic society, this issue demands diagnosis and treatment, not just at the level of the symptoms, but to discern its cause or causes in order to bring about a healing, a cure, and future prevention. This awareness points precisely to the alternative meaning of the same term, New World, to the indigenous. Here, in place of a rhetorical absurdity, we find the recognition of an objective reality of the world literally having been made new, with in the Western Hemisphere and beyond, as the era of European exploration and colonization effectuated an unprecedented transfer of human beings, plants, animals, language, religions, and cultural practices to new locations where they otherwise would never have met, and in the process engendered the geopolitical world that we know today, with its distribution of wealth, power, and influence. Even as we recognize the massive scope and sweep of this phenomenon over the past 5 centuries, a mere nanosecond of the whole of human history, we fail not to be cognizant of such prior developments as the traffic in African captives across the Sahara and via the Indian Ocean, driven by the Arab countries before the transatlantic exploration led to its own centuries. I'm sorry, wait a minute, I've got to rephrase that. So it means recognizing that this traffic in African captives and their potential for labor, production, skills, culture, and other is rather interesting, because we find that there's this global market developing for this, but that Africa itself does not have a need to import stolen labor from other places. So that's a matter for further contemplation and investigation. The second factor here is that we also recognize that the slave trade was not the beginning of African transoceanic exploration or of the African presence in the Americas, as is confirmed by many Native American accounts. And Dr. Weidman, one of your students from Peru, shared with us that he learned that from his grandfather, that of an oral tradition of Africans coming to that country, long before. And of course, these transoceanic African voyages took people to destinations like the Andaman Islands off the south coast of India and Melanesia in the South Pacific. In North America, the focus of this presentation, the strongest physical evidence of African presence is to be found in Mexico, which would also receive a portion of the early so-called transatlantic slave trade. Indeed, the first captive Africans to be brought into a British-claimed colony in North America in 1619 were bound for Mexico when they were stolen by a privateer or legalized pirate ship and brought to Virginia 401 years ago this month. The Middle Passage during the era of the Middle Passage, the African impact here would have an undisputedly disproportional historical, cultural, economic, and spiritual impact on the nation and the rest of the world. And that's in spite of the fact that North America only received 5% or less of the total traffic that was called the transatlantic slave trade, which mostly went to Brazil and then also to the Caribbean islands. While much of that impact certainly arose from the interaction of Africans with European descendant enslavers and owners of an extensive network of related business enterprises, the cross-cultural experiences, past and present, that are of the greatest interest in this discussion is that between, quote, the first and the forced, between the indigenous First Nations and captive Africans who brought their own indigenous knowledge, skills, culture, and spirituality, the very qualities that made them so coveted to be forced laborers and builders of nations in the first place. With due recognition of the African presence and interaction with native tribes before slavery, it is clear that the inseparability of the two historical narratives stems largely from the fact that slavery and genocide were interdependent, each being both the cause and effect of the other. While that was true, it is also true that there were any number of motives, interests, and common causes that united Africans and indigenous Americans in any number of ways. In some cases, the interaction was so thorough that there are nations of so-called Black Indians, where folks simply intermarried, like the Shinnecock of Long Island, New York, or the Wampanoag of Massachusetts. Among the most historically significant alliances between Africans escaping slavery and Native Americans escaping settler encroachment into the Spanish territory of Florida, the invasion, one of the most significant alliances was that combined escape of Native Americans and African Americans into Florida, which was the site of the United States' first quote unquote foreign war, in order to effectuate quote Indian removal and quote the recapture of quote slave property. Native and African American survivors of that decades-long war would be marched on the Trail of Tears to present-day Oklahoma. So we have our kind of historic connection with Dr. Jacobs' narrative that he shared. And there were also ostensibly adversarial relationships, such as the tribes which claimed to support slavery and claimed ownership of slaves, or the Buffalo Soldiers and Seminole Negro Indian Scouts who served with distinction in the U.S. military forces during the so-called Indian Wars. But as with so much having to do with survival under such circumstances, even these apparently adversarial relationships were not always what they appeared to be, and often included much mutual respect. In cultural production, especially among the Seminoles of Florida and Oklahoma, the blend of African and native cultural influences is evident in textiles, architecture, utilitarian items, and other forms of creative expression. However, arguably the most substantial bond between African and Native Americans in indigeneity is in the spiritual realm as applied to life in the physical world. We might compare the Native American concept of the 7 generations with the traditional African concept of the 3 peoples. The Native concept reminds us that every word, every action, excuse me, that we take in the present moment affects the 7 generations, which actually has 2 interpretations, which are complementary rather than competing or contradictory. On the one hand, it refers to the next 7 generations, just as we are reminded daily of how decisions made by the past 7 generations affect us today. On the other hand, it is also interpreted as the 7 living generations. That would be ourselves, our parents, our children, grandparents, grandchildren, great-grandparents, and great-grandchildren, all of whom are considered as being affected by our actions. The African concept of the three peoples reminds us that we, the living, are also the embodiment of all of our ancestors since the beginning of time, who are physically alive and present within us, as are all our future generations yet unborn and that will ever be. But both of those concepts have in common is the proverb which began this discussion, which is that the past is present, the future is now. And that the need to honor our ancestors and provide for the well-being of our future generations is what must guide and inform our every thought and action in the present moment. Indeed, an African proverb reminds us well that we must, quote, do everything in a way that our ancestors could not have done it better. In the present day, the inseparable bond between Africans and Native Americans is stronger and more necessary than ever as the world bore witness to the open and prominent embrace of the Black Lives Matter movement by the largest gathering of Native nations in one place in the history of the continent, which took place at Standing Rock in 2016. And many of us will remember that was to oppose the pipeline, but more in a more positive sense, to defend and protect water, and because water is life, and it's also that bond, the present day bond, is also evident in the ready embrace of the revival of the 1968 Poor People's Campaign, which was founded by Dr. Martin Luther King Jr., but he did not live to see it. The embrace of the Navajo Nation's demand for economic justice as one of its first initiatives. So it is a new world indeed. So these observations regarding the two interpretations of the of the term New World, one invasive and exclusive, the other indigenous and inclusive, serve the purpose of our guiding our creation of the post-pandemic healthier society. Now, within this whole context of the settler discourse, that interpretation of New World, we have to make special mention of another language phenomenon that definitely needs to be examined, and that is this division of humanity into these racial categories of white, black, red, and yellow, which coincidentally are the Native American four sacred colors. This myth of race is a political contrivance with no scientific basis, which ascribes different socioeconomic status to individuals based on phenotype. In other words, it is a simple strategy for dividing and conquering a large population, which a smaller group seeks to control. The Human Genome Project has demonstrated, however, that fully 98.2% of all human DNA is identical, which means that all human genetic differences that can be perceived are accounted for by only 1.8% of our total genetic makeup. So these include gender, height, body shape, innate talents and proclivities, including our phenotypical characteristics. Yet these so-called racial categories stubbornly persist, precisely because they continue to work so well to accomplish their intended purpose, in much the same way that by giving a portion of an enslaved population an arbitrary measure of unearned rewards, power, privilege, and status, they could absolutely be relied upon to fight for the upholding slavery against their less privileged brethren, rather than to fight alongside them for freedom against their oppressors. This indeed merits diagnosis from a behavioral health or mental health issue. My wife, Dr. Wallace Tinnie, has done extensive research on the rhetorical methodologies for maintaining this dysfunctional fixation on the existence of a non-existent reality. Much like the, okay, somewhere in here, much like the fairy tale of the Emperor's New Clothes. You know, this is the one where the Emperor was never satisfied with the clothes that were prepared for him. So the tailors finally convinced him, well, you'd just be better off. Actually, you're fully clothed the way you are, the people, and he goes naked in the public and he is displaying his new clothes, and everybody in the public has to agree that he's not naked. And you have to think about the thought process that requires, and the fact that the people who participate, and we can think now of lynch mobs, we can think of people who went to segregated parks and enjoyed certain things knowing that other people could not. And how do you rationalize this? What is the consequence for mental health? So, okay, with that, let's, that kind of lengthy exploration of language will sort of make it easier to look at the role of land. And here, I'll just go through a couple of things. The motto of the modern American state and that of the old indigenous kingdom of Hawaii is said to have first been spoken by King Kamehameha III on July 1843. Is this, and I have to apologize to any native Hawaiians for wrecking this, but essentially it's Ua Mao Ke'ea Aka Aina Ikapono, which translates approximately in English as the life of the land is perpetuated by righteousness. According to at least one commentator in Hawaii, righteousness is defined as, quote, being right with God, right with nature, and right with the rest of humanity. And righteousness is learned and practiced through the hula discipline, which is much more than just a dance that has become such a tourist attraction. The hula discipline is the practice of, quote, doing the right thing in the right way, in the right place, with the right people, at the right time, the first time. Here again, another indigenous confirmation of the prime importance of the present moment and its consequences. When a delegation called the Dagara Peace Commission, representing the Dagara people of northern Ghana and southern Burkina Faso in West Africa, who specialize in spiritual divination, visited Miami some years ago and conducted spiritual readings, they emphasized the need to give conscious thanks to the land as a first priority and never to take the land for granted. It does not seem obvious at first blush that land and history are actually one and the same thing, called by two different names. Yet it requires only a moment's reflection to appreciate that there is no land without history and no history without land. Human cultures are shaped by the land that is occupied by them, and the human presence shapes the land along with other natural forces, such as winds, waters, earthquakes, and the rest. Indeed, when each of us walks on the beach, our footprints change the shape of the earth. Here, I want to inject, as we talk about land, a note on economy, excuse me, and this was mentioned yesterday, and Dr. Maria Luisa, I think you had brought it up. Okay, essentially, there's some issues with this. The fact that the economy is not as stridently charged as notions of New World or race makes it even more insidious and more entrenched in the nation's collective psyche without being questioned. And without any real examination of how economy is defined. Clearly, the recent spikes in the new cases of COVID-19 infections and deaths in the United States is related to a premature rush to, quote, reopen the economy based on a supposed concern with lost jobs and income. This view is based on a well-worn knee-jerk tendency to define the word economy in financial terms, as in assessments of gross national product as a measurement in dollars. We are far better served, however, by a more accurate definition and measurement of our financial health based on the real sense of the term, which is the combination of natural resources that a country has and the ability of its people to make the wisest use of them for survival and sustainability. The word originates from the Greek word oikos, meaning the house. Oikonomos meant the management of the house's resources. In this time of global pandemic, we are reminded of how during World War II, the nation was quick to convert luxurious ocean liners into troop ships and to redirect the automobile industry into production from passenger cars to military vehicles and the like. It is nothing less than amazing and tragic that we hear our government today and corporate leaders fretting over whether businesses like tourism and hotels can resume, which is like asking firefighters how soon we can move back into our house while it's still burning. Instead of looking at how hotels, for example, can be modified to provide much needed additional hospital rooms where needed. And of course, that's just one example of many. So essentially, what we're looking at is that when we consider our codependency is not the right word, but the fact that the land is part of us and we are of it, that we, as we confront this pandemic, we could be looking at certainly different places than the bottom line at the end of the day in dollars. So with that, I'll move to the final part of this, which is essentially the future and what do we do proactively. I'll start off with just a few modern proverbs and quotes. One of those proverbs is that problems are rarely solved by those who created them in the first place. Another is mental health is defined as persisting in the same behavior with the expectation of different outcomes. A third one, it is better to light a lamp than to curse the darkness. A couple of quotes that I think you'll appreciate. Machiavelli reminds us, ever the pragmatist, that it is just as difficult and dangerous to try to free a people that wishes to remain servile as it is to try to enslave a people that wishes to remain free. And then we have our German friend, Johann Wolfgang von Goethe, who reminds us that none are more hopelessly enslaved than those who falsely believe themselves to be free. All of those have kind of a permanent timeliness in the society that we're living in now, but it's worth pointing out that all of those, what they all have in common is that they are essentially reactive. They are responses to a situation rather than the creation of a new one. So to set the stage for how do we proactively create this new society, what I'd like to propose is that we start off with something that I'm going to call a kind of generalized understanding of there being one universe, one and only one, that includes everything physical, spiritual, past, present, future. Everything that happens in the universe stays in the universe. So whether we forget it, ignore it, lie, deny it, it's there and it stays there, which means that we are more strengthened by acknowledging, embracing, and connecting with it than by not doing so. In the universe, there are no aliens. There's no us or them in the universe. Everything in the universe is we. This is an understanding, certainly at the opposite end of the spectrum from the idea of the universe being something that man can control. But I believe that this is an understanding that allows us to look at this novel virus in a different way. It's novel, but it's not new. Dr. Reyes-Contreras yesterday mentioned how some of the indigenous peoples in Mexico were not too inclined to listen to government or authorities because we've had pandemics many times before. We know how to deal with this. And that of course raises this very interesting question of what is this meeting place of that kind of indigenous knowledge that, you guys who call yourselves scientists, you're the younger brother, you just got here. There's so much that you obviously don't know, but at the same time, for whatever else can be said about the scientific method that evolved out of that humanist tradition, knowledge has been brought forth that has been extremely valuable. And so it brings up that the question that was very much part of the discussion yesterday, which was, well, how does science, how does modern medicine really incorporate indigenous knowledge in a productive way? And I would respectively submit that the more important question is the opposite. How does indigeneity, which is kind of timeless and has been here, incorporate this modern knowledge in such a way that it becomes a productive force, so that when we confront the coronavirus, we're not confronting this as something alien or unprecedented, but it's kind of like something that we have to, how can I put it, fight with instead of fight against, if that makes any sense. So that kind of globalized, universalized view of this allows us to look beyond just the virus. In other words, instead of just, well, what do we do about that? Well, how do we move holistically? And essentially, I would say that this involves today functionally, basically a decolonization of the lands and of our minds. I didn't really insist as I intended to, and I'll just jump back to that again. That whole idea of the racial categories, the fact that we even continue to call ourselves white and black. Why are we doing that? Those categories were not created in the interest of the majority of humanity. They were created for oppressive purposes. Me calling myself black only serves the purpose of giving legitimacy to somebody being white. And so here again, this is where this interrogation of language becomes so important. So I'll conclude with just a few places, a few directions that we can look at as starting places or continuing places in creating the post-pandemic society, with keeping in mind that the future is now, so that the post-pandemic society must be the one that we are creating in the present moment. And I have a few random notes here that I think will, I mentioned integrating modern science with indigenous. Environmental awareness. I mentioned environmentalists earlier, and that very, I think well-found and useful trope of considering all the land on planet Earth as a single island, so that everything is here. Actually, I did not mention that. I should have, and also regarding land that we know that we learn in school 70% of the Earth's surface is covered by water. We're separated from other continents by thousands of miles, but as an African priest reminded me not too long ago, when we pour libation here to honor the ancestors, we are reminded that beneath those oceans is the land, and that the libation reaches all the way back to the African motherland. Again, another way of looking at the primacy of our being aware of our connection to the land. But what I think is interesting is here in the States, this whole environmental movement, which is a misnomer, because the environment is not something that surrounds us, as the name suggests. It's we are it, and it is us. We're all made of stardust, as it were, in the universe. But I took note when I was in Brazil of a park that was being restored in Bahia, and the sense of restoring the environment there was not only in terms of ecology, but with a very strong awareness of the medicinal and spiritual properties that all of those various flora and fauna had. So that's something that we can look at. Sacred places. The fact that there are places on planet Earth that have been, shall we say, consecrated by the struggles, the triumphs, the tragedies of our ancestors, and that these places need to be identified, restored, revered, protected, defended. And here in South Florida, I happen to be involved with several of them. Virginia Key Beach, which was a kind of an extraordinary, much loved, in spite of segregation, colored park in the 1940s and 50s. The African Cemetery in Key West, the Loxahatchee Seminole Battlefield in West Palm Beach, in Palm Beach County, which is north of Miami. The sense of land as being the historical text is one that I think will be very helpful to us. Gardens, self-sufficiency. The number one crop being grown in the United States is grass, lawns, with a whole industry of lawn mowers and carbon footprints and so forth. We're not growing food. So we have to rethink. Education. Here in the States, there's a lot of discussion and brouhaha about children being kept home from school. Should they be sent to school? Is it safe? Parents being burdened by it, both by the fact that it doesn't allow them to do things that they could do, or they feel challenged to keep up with the children's homework. But we have a real opportunity there. There's a proverb that says you're not being educated if you're not learning about you. Here's our opportunity for our children to learn who they are, their family trees, their talents, and so forth. The native tribes are doing.
Sir, I'm sorry. It's wonderfully. I really don't want to stop you.
I'm going to end with this. I'm going to end with this. Yeah, okay. I knew I was going a little long, but let me ask. I'll just end with 3 words from Mohandas Gandhi. We have to be the change. Thank you so much. I knew I was going to get a little bit too loquacious, but thank you again for the opportunity, and I hope to have contributed.
It was really wonderful, and I'm really I'm truly indebted to you because, you know, yesterday we were talking about end of ideology. We actually wanted to further ensue this debate that it's not actually end of ideology, it's about end of the Eurocentric perception of ideology. And we need an indigenous perception now. We have the indigenous philosophy and ideology need to take a forefront. And this is what clearly was explicit in your presentation. It's a wonderful paper, and and I'm glad you have written it, you know, so I'm going to publish it and you have to keep it for us. So I think we really, Professor Wheatman, I think we really don't have time right now for the discussion at this moment, but definitely soon after the Professor Bhattacharya's presentation, we will take all the Q&A. I think if all my panelists will agree, we may extend this session for half an hour if you all agree to it, because it's already 9:30 and we may need to get into it. So now I request Dr. Bhattacharya to please come on dais. Dr. Bhattacharya is a practicing doctor working with the indigenous communities in West Bengal and Bihar border in a place called Raiganj in West Bengal. He's presenting to us COVID-19 pandemic and social paranoia. Dr. Bhattacharya, are you there? Dr. Bhattacharya? Yes, yes. Yeah, please unmute yourself. I'm reading your profile. Please unmute yourself if I could. Yeah. Please unmute yourself. Yeah, please unmute yourself. Because I can't, I'm trying, but I'm unable to unmute you. You can't unmute because someone else. Yeah, because you were invited. So I think you need to unmute yourself. Just unmute yourself, your microphone. You need to unmute your microphone. Okay. Meanwhile, I'll quickly read Dr. Bhattacharya's profile. Dr. Bhattacharya did his MBBS from Calcutta Medical College and PhD in History of Medicine. He's socially committed doctor and actively engaged in community health practices. He presently works in Raiganj town of West Bengal. Apart from his community health service, he actively publishes and contributes in the health and healing research. His major research contributions are he's reviewer of the Bulletin of the WHO, Graduate Journal of Social Science, Social History of Medicine, Indian Journal of History of Science, Indian Journal of Medical Ethics, and others. He's author of book Biomedicine, Theke Nojordari Medicine. That means From Biomedicine to Surveillance Medicine. Second edition, which got published in 2017. He's editor Bharatiya Patbhumite Chikitse Bijunor Itihas. Eki Shantarshipta Parelochana, History of Medicine in India, and Appraisal. It's a book in Bengal, which has been translated. In translation, it will be called as History of Medicine in India and Appraisal, which was published in 2009, and also contributed a chapter on the body epistemology encounters in colonial India in Making Sense of Health, Illness, and Disease, edited by Peter W. Hawking and Vera Kalitsats from Amsterdam in 2004. So the best part of Dr. Bhattacharya is that he is a best combination of academics and practical applications of health practices among the indigenous communities in South Asia. So I welcome Dr. Bhattacharya, but again, Dr. Bhattacharya, you have to unmute yourself. I'm sorry to say I'm unable to unmute you because here the system is saying I cannot unmute you. So you need to go to your microphone and try to unmute it. Dr. Bhattacharya, can you unmute yourself? You're not able to unmute yourself. Can you rejoin? I think we need to rejoin you. I'll remove you for a while and let you rejoin again. Will it be okay? Let me call you. I'm sorry for the technical glitch, which is unavoidable certain times.
Dr. Tinnie, that was a lecture of decolonization. Thank you very much. Really, I really enjoy it. To the point.
I'll quickly just give a call to Dr. Bhattacharya. As I already told you, he's in a region which is severely affected by floods and lots of, I think he joined, yeah, now. And we could see, but again, you need to unmute, Dr. Bhattacharya, you need to unmute yourself. You go to your microphone down and you can unmute from there. You can't unmute someone else. Yeah, now you're unmuted. Yes, perfect. Now you're unmuted. Your video is slightly blurred, but your voice is perfect. Okay, yeah. Go ahead, sir. Go ahead, Dr. Bhattacharya.
Can you hear me now?
Yes, perfectly. Your voice is audible. Perfect.
I am afraid I am at the fag end of the meeting, and everyone is actually mentally exhausted to an extent.
I don't think so. You're all active. Go ahead, sir.
My big thanks to Dr. Senegar, who has made this seminar possible to bring those scholars across the globe. At the start, cross-cultural experiences. This is the basic pivot on which the seminar in a good way hinges. But I will problematize these cross-cultural experiences because it's not malaria, it's not a disease like malaria or diarrhea or anything like that or smallpox. It's an unforeseen pandemic which we have never experienced in our living experience. I have changed my title a bit. COVID-19, Beyond Biology in the Land of Politics and Society. From my medical background and from my social activities and from my political and other readings, I am presenting my paper as quickly as possible. At the outset, I shall stress on the fact that present devastating pandemic, COVID-19, goes contrary to our Indian indigeneity of social cohesion and neighborliness. We are facing an unprecedented and almost directionless situation where social people cannot rush to extend their helping hand to help others, as in situations like flood, wildfire, fire, or famine, as is the usual history of normal human habits in India and elsewhere. Paradoxically, for safety, we have to maintain a safe personal social distancing of at least 6 feet or more after airborne transmission has been accepted scientifically. Truly speaking, this pandemic is at loggerheads with indigeneity. Indigeneity is moved on indigenous processes, ideation, and resilience, to name a few. Contrarily, this pandemic is absolutely global, effacing all nuances and shades of cultures around the globe. The processes surrounding the pandemic are entirely high-tech, structured, and scientifically sound. No empirical or experiential knowledge or cognition is allowed to inhabit in its ambit. We can recall the variolation versus vaccination debate and struggle extended until the first half of the 19th century in India. Let us do some quick appraisal of facts related to the pandemic. The virus is SARS-CoV-2, the disease is COVID-19, and the impact is the pandemic we are witnessing. According to the estimate of Worldometer of yesterday, coronavirus cases, 21,89,665 deaths, 7,57,647 deaths recovered, 13,940,000 and 2,205. In US alone, death toll is 170,419, more than double the lives lost in Vietnam War, spanning 10 years. The disease arises from an interaction between the virus and the person it infects and the society that person belongs to. Some people who become infected never show any symptoms. Others become so ill that they need ventilators. Statistically speaking, 80 to 81% of the infected population remains asymptomatic, polysymptomatic, or with little symptoms and do not require any hospitalization. 14% of the infected people may require hospital admission and oxygenation. These people are grouped as mild to moderate COVID patients. Among the rest, 5% of the infected population develop severe symptoms and do need ICU care, and also it may be necessary for further interventions like intubation, extracorporeal membrane oxygenation, and antiviral or steroid therapy, or both at the same time. About 49% of the severe COVID-19 group may die. Hence, mortality is not very high. As in Ebola, it was about 50 to 55%. But owing to the presence of spike glycoprotein on its surface, the virus has attained the capability of very high infectivity. From zoonotic to anthropozoonotic, this is a very intriguing question. For thousands of years, a parasite with no name lived happily among horseshoe-shaped bats in southern China. The bats had evolved to the point that they didn't notice. They went about their nightly flights unbothered. One day, the parasite, an ancestor of the coronavirus, SARS-CoV-2, had an opportunity to expand its realm. Perhaps it was a pangolin. The genetic pathway remains unclear, but to survive in a new species, whatever it was, the virus had to mutate dramatically. More recently, the coronavirus found a new species, ours. Scientists have identified genes for as many as 29 proteins, which carry out a range of jobs from making millions of copies of the virus to suppressing body's immune response to producing plethora of symptoms, including fever, cough, severe respiratory distress, loss of appetite and smell, blood clotting disorders leading to strokes, acute myocardial infarctions, and many more. The two most sinister symptoms which cause almost immediate death of a severe COVID-19 patients are: one, cytokine storm, when the entire immune system behaves irrationally in an odd way to which our bodily system is not attuned to; and two, fulminant myocarditis, when all of a sudden irreversible severe heart failure begins to take place. From scientific analysis, a neighbor's cough that sends 10 viral particles your way might be enough to start an infection in your throat. But the hair-like cilia found there are likely to do their job and clear the invaders. If the neighbor is closer and coughs 100 particles towards you, the virus might be able to get all the way down to the lung. Moreover, it is also found that the virus can start in the throat or nose, producing a cough and disrupting taste and smell, and then end there. Or it might work its way down to the lungs and debilitate the organ. How it gets down there, whether it moves cell by cell or somehow gets washed down, is not known. Two extrapolations can be made here. One, biological characteristics of the virus translate into personal social distancing, the new norm of society. And two, it opens up a space of uncertainty of knowledge, which leads to uncertainty in social psyche of a population. The first one is further substantiated by a paper published in Science. It informs, given how little is known about the production and airborne behavior of infectious respiratory droplets, it's difficult to define a safe distance for social distancing. Now the question comes up, why such uncertainty? Even after hardest, dedicated researches of the best of the scientists and physicians, we have yet to exactly know the little fact that how the virus moves from nose to the lungs. Within the interstices of the space of uncertainty, plethora of pseudoscience, anecdotes, and obscure evidence is burgeoning, against which physicians too cannot always remain immune to the pressure of society and media. Is it indigeneity? Perhaps no. It is commented in the most celebrated medical journal, New England Journal of Medicine, in a time when the rational emotional scale is tipping to the emotional side. We begin relying more heavily on anecdotes, particularly personal experiences that may carry inordinate weight in our minds. Journalists use the power of stories to connect with readers and tap at their emotions. Physicians trained as scientists are expected to follow a hypothesis-driven, rational, evidence-based approach to clinical decision-making. But we, physicians, too, can be swayed by stories under the pressure of a crisis. We're living through an unprecedented biopsychosocial crisis. Physicians must be the voice of reason and lead by example. We must reason critically and reflect on the biases that may influence our thinking processes. Critically appraise evidence in deciding how to treat patients and use anecdotal observations only to generate hypotheses for trials that can be conducted with clinical equipoise. We must act swiftly but carefully with caution and reason. This is a cautionary note to all, including physicians, scientists, academicians, general populace, and all thinking persons. In another context, not in unusual pandemic situation, Sir Michael Marmot, the proponent of social determinants of health and also health inequalities, asked, why treat people and send them back to the conditions that made them sick? He further added, as doctors were trained to treat the sick. Of course, but if behavior health are linked to people's social conditions, I asked myself whose job it should be to improve social conditions. Should the doctor or at least this doctor involved? Here comes the question of social determinants of health and sustainable development goals propounded by the WHO. These issues are internationally accepted, practiced, and applicable. These basic questions of public health are completely forgotten or pushed to the margin during this unprecedented pandemic situation. How did zoonotic to anthropozoonotic happen? We must realize that in our crowded world of 7.8 billion people, a combination of altered human behaviors, environmental changes, and inadequate global public health mechanisms now easily turn obscure animal viruses into existential human threats. We have created a global human-dominated ecosystem that serves as a playground for the emergence and host switching of animal viruses, especially genetically error-prone RNA viruses, whose high mutation rates have, for millions of years, provided opportunities to switch to new hosts in new ecosystems. Few years ago, in a research article, it was noted Land use change has the potential to impact disease dynamics directly and indirectly by changing the abundance, demography, behavior, movement, immune response, and contact between host species and vectors, as well as altering host community composition. There is a multitude of pathogens, types of land use conversions, and proposed mechanisms for altering infectious disease dynamics in humans and animals. And a summary of the state of the literature of this emerging field is needed in order to identify gaps in our understanding and to define future research needs. One may be curious to know, what does this land use change and human-dominated ecosystem cause to us? And also why and how did it happen? Some plausible answers are: one, it is human greed for maximization of profit and commoditization of everything and everyone that has made possible the virus happily harboring within bats for millions of years to spill over to human body in a very short span of time. And two, our mastery over nature for some 300 years, accentuating in the post-World War II era, has bounced back. For further knowledge, we have to take into account the history of PREDICT project. It clearly shows how medicine, disease, politics, and economics intersect one another. PREDICT project. 2 months before the novel coronavirus is thought to have begun its deadly advance in Wuhan, China, the Trump administration ended a $200 million pandemic early warning program aimed at training scientists in China and other countries to detect and respond to such a threat. The project, launched by the US Agency for International Development, USAID, in 2009, identified 1,200 different viruses that had the potential to erupt into pandemics, including more than 160 novel coronaviruses. The initiative, called PREDICT, also trained and supported staff in 60 foreign laboratories, including the Wuhan lab that identified SARS-CoV-2, the new coronavirus that causes COVID-19. But the shutdown of a program of immense importance like PREDICT project didn't go without protest. United States Senators Angus King and Elizabeth Warren sent a letter to the US Agency for International Development, USAID, requesting information regarding the agency's recent decision to shutter PREDICT, a program established to identify and combat viruses that may generate global public health emergencies, such as the recent coronavirus. The joint letter follows up on a November request from Senator King, who asked for information on USAID's decision to end PREDICT. In response to Senator King's initial letter, USAID indicated that it intends to initiate a successor project, but just 2 months away from the project's March 2020 closure. No additional details regarding this replacement have been released. A new medical industrial state politics complex. In the midst of the vortex and twists in politics and history, scientific inquiries, endeavor, and relentless pursuit had to yield to politics, which can be called as medical industrial state politics complex and extension of military industrial complex. In his farewell address as president on January 17, 1961, Eisenhower warned his countrymen of what he called the military industrial complex, a huge and permanent armament industry that, together with an immense military establishment, had acquired great political and economic power. As in case of the PREDICT project, the same thing happened in case of hydroxychloroquine. Trump touted the drug as game changers on 19th March 2020. After Trump's initial assertions, the FDA, Federal Drug Authority, still facing criticism that its delays in approving testing kits for the virus hindered prevention efforts, issued an emergency use authorization, EUA, on March 28 that allowed for the use of the drugs to treat patients with COVID-19. Although the EUA's scope was limited to permitting distribution of chloroquine and hydroxychloroquine from the federal stockpile, its issuance was widely yet incorrectly reported by Trump and others as meaning that the FDA had approved the drugs for the identification, the Center for Disease Control and Prevention, CDC, went so far as to publish doses of chloroquine and hydroxychloroquine for the use in patients with COVID-19, though it later removed them from its website. Meanwhile, serious concerns have been raised about the adequacy of the available studies of these drugs. To add, quite disturbingly, physicians and health workers in Brazil are threatened to court death for failing to use hydroxychloroquine to treat patients. The unfavorable outcome to the study provoked the animosity of those who support using chloroquine to treat COVID-19, first in US and then in Brazil. Moreover, besides suffering death threats, the authors of the study may soon need to respond a legal action taken by 3 public prosecutors. Now, not being in tune, an internationally respected and trusted independent organization, CDC, has been stripped of some of its regulatory and advisory roles. Before putting an end to this glaring signs of medical industrial state politics complex, it should be mentioned that even drugs have been politicized in the pandemic. 5 months ahead of general election, Democrats are escalating their attacks against Republicans over the use of malaria drug to treat COVID-19, dragging a highly polarized medical debate even further into the political realm. The debate has effectively served as a dividing line in US politics. In large part, Trump's supporters and sympathetic media outlets echoed the president's enthusiasm, while Democrats, with some notable exceptions, generally sided with scientists who insisted that there was no reliable science indicating hydroxychloroquine could help treat COVID-19. Society and public health after the pandemic. It is well recognized that every pandemic tries to find and construct an other who can be made scapegoat for which hunting and shield one's own fault lines. But diversity is valuable for its own sake. It encourages understanding and dialogue between cultures and sharing of points of view and ways of being. And it has always been a fuel for research and innovation. There is a rising tide of isolationism and xenophobia in many high-income nations, particularly the United States and European countries. It may be argued that the SARS-CoV-2 pandemic is forcing us to face the fact that progress towards the sustainable development goals is fragile, as those populations, especially in countries like India and Bangladesh, on the path towards living poverty, are now at increased risk of falling behind. Poor populations lacking access to health services in normal circumstances are left most vulnerable during the times of crisis. Misinformation and miscommunication disproportionately affect individuals with less access to information channels, who are thus most likely to ignore government health warnings. Some probable and indelible changes are most likely going to take place in the post-pandemic era. One, our health system will come into play across the globe, where tropical neglected diseases will be more marginalized. According to the WHO, in 2018, 9 to 110 million were affected by TB, leading to a death toll of 1 lakh per year. Global under 5 mortality due to diarrheal diseases were 5,20,000. 228 million people were infected by malaria and 4,05,000 died. These diseases being invisible and indiscernible. 2, more high-tech health system utilizing ventilators, ECMO, high pressure or hyperbaric oxygen supply, and costly medications may replace treatment protocols which are less costly, accessible to most of the peoples. Personal social distancing may reconstitute our already constructed virtual individual-centric solitary life. 4,
the difference between clinical health, where individual patients are the concern, and public health, where community people are focused, may be erased, which is already underway. 5, the difference between health and healthcare, which is a commoditized service to buy from any corporate hospital at high cost, will be more and more effaced. Health and health care is most likely to become coterminous. 6, disease-centered vertical programs may be replacing community-centered horizontal programs, paving the way for more investment in healthcare for corporate profits. 7, telemedicine and other forms of virtual medicine may disintegrate the millennial physician-patient bondage at a personal level. The COVID-19 pandemic will come to an end eventually, but what is needed afterward is a renewed focus to ensure that health is not a byproduct of privilege. The next sentence after not a byproduct of privilege could be, health is my right. We can only historically cite that in June 1948, on behalf of the National Health Service, UK, a leaflet was delivered to every household in UK. The leaflet read, "It will provide you with all medical, dental, and nursing care. Everyone, rich or poor, man and woman, or child, can use it or any part of it. There are no charges except for a few special items. There are no insurance qualifications, but it is not a charity. You are all paying for it, mainly as taxpayers, and it will relieve your money worries in time of illness. There are no insurance qualifications, but it is not a charity. You are all paying for it, mainly as taxpayers, will relieve your money worries in time of illness. Our world will never be the same in the post-pandemic era. We'll have to learn to live with the virus. These are the greatest societal, cultural, political, and economic changes which are in the offing. It is biggest challenge to indigeneity. Thank you all. Thank you all. Can you hear me?
Yes. Thanks a lot, Dr. Bhattacharya. I'm really glad because, you brought out a different perspective in context of the South Asian or the Asian ancient understanding of COVID-19 or related pandemic situations. Because so far in the last 2 days, we had been highlighting more about the disaster which COVID-19 is coming up and how much we have to be precautious about it. On the contrary, yesterday, of course, Professor Miguel's presentation highlighted slightly on this aspect because he was talking about that how the community solidarity is helping them to do away with this threatening, what we could say, the threatening challenges of COVID-19 because they are very strongly associated to their land and indigenous knowledge systems. So for them, battling this pandemic is not a big issue. Of course, even in the beginning, Dr. Patel's presentation was talking about this problem because yesterday also he said that he was stating about the same thing that the pandemic is not something which is new. We already have other diseases like which you also highlighted, like tuberculosis, malaria. These are equally challenging pandemic kind of diseases for the indigeneity. So how we are going to situate COVID-19 in already susceptible to all such kinds of epidemics, the indigenous population, because they are already devoid of many of the healthcare services. And as you are now telling about the whole mechanization and the amount of money being infused, the economics behind the whole pandemic of COVID-19 will further accentuate the trouble between indigeneity, healthcare, and community practices. Exactly. I'm really glad you brought about these ideas. And now I think we all can come on the dais. I request all the 4 panelists to please open their camera and be visible to all, because when we will be putting this whole seminar on YouTube for the public platform, visibility of all the persons is required. So I please request, I know some of you have taken a little break and gone out for a cup of coffee or something. If not, then please come on dais and let's have a tile view and bring everybody on platform. Please, yes, I'm glad everybody's there. So let's have now an open discussion.
Bennett, can you see me there? Can you see
yes,
me there?
I can very well see you. Thank you, Professor Dennis, for being here. And it's really amazing for these 4 wonderful talks, which actually, because, you know, this is, yesterday we started the whole idea of decolonization. And today we we actually put it on the 2nd gear. Yesterday was a kickstart and today it was like going on a further gear, like putting out not only because with the Dr. Jayanta's presentation and Dr. Patel's presentation, we brought into light the ground realities that these are the realities of the indigenous people in ground. And then Dr. Tvli also, Dr. Jacob brought into light how the indigenous communities in Northern America and of course in Canada, which of course is part of all North America, how even indigenous communities are becoming victim of this COVID-19 more than anybody else, because a lot of their traditions are lost. And when they are trying to work on the resilience patterns, there are certain hurdles to it as well. And of course, Professor Tinnie, it was amazing. The whole theoretics which you brought into this light about the decolonization and how we have to look into various dynamics of the native communities. It was amazing. So we really want, Dhanraj, I really want you to come up with any of the questions if we have from the YouTube of the live audience. And MLV, please be on camera as well, because your inputs are needed as well. Yes, Professor Dennis, we'd really appreciate your comments and your points of discussions on all these 4 wonderful presentations. Yeah, your microphone is on. Yeah.
Binna, you summarized them so well just now that you took the words that I was about to say. So let me be, a little more specific. Dr. Patel, his presentation was so community-based, showing how the communities throughout India have been mobilized over the last decade or so to coordinate health services in ways that are very community-based, very personalized, with community-based health workers. And so the challenge we have now is to see how that kind of a system, which is in place, how does it respond? How did the people respond and the systems respond to this epidemic? And my question of them there at the end revealed that the virus is actually a very low level so far in those communities. So that may be an indication that through that health education, through the continuous public health issues, the sanitation, that works for these rural communities in general, but also it's an indication of indigenous communities around the world who have been able to maintain an integral healthcare system along with their state healthcare system in their own traditional ways. When we come to Tvli Jacob from Oklahoma, by the way, Tvli, my years have been in Oklahoma also, and I have my PhDs from the University of Oklahoma. Welcome, Oklahoma State, Professor. But the idea there is that the local community, once again, and all over the United States and North America, Tvli, reported how they're responding. And I think it was the Apache that closed their borders. They then, their casinos were then not being patronized any longer. So they actually turned that into ways of promoting their own community with rooms and all. And Jean turned on that issue too, in the sense, why don't we turn our hotels into, instead of profit motive buildings for the public tourists to then benefit the community. And so that is a strategy that Native communities, an aspect we haven't quite gotten into here, is how do they shift their resources, their institutional resources. And especially when it comes to a point we haven't brought up is tourism. There has been probably 15, 20 years of purposeful tourism development by nation states of indigenous communities, trying to fund them in various ways to bring extra dollars into the communities. And so in the cases of Alaska that I know about, I've spent time in Alaska, and hearing their current situation, their foods, their subsistence hunting and fishing has continued, and so they can rely upon that. But over the years, they've needed cash, and in order to bring in modern foods. And so the issue is, now that we're in social distancing, and the planes little planes aren't arriving, or the boats aren't arriving, then those communities are there to self-defend and resort back to their traditional ways. So here we've had kind of health development. Dr. Patel's talking about health development of these communities. And I'm bringing up the idea that tourism has been a major industry, and that is basically stopped. And so yesterday, Maria Luisa brought up the idea, well, what is going to happen to the food production? The Native communities who are food producers, especially those in Alaska that I'm familiar with, they're able to produce their subsistence foods. But what about those that are marginal to the urban areas or within urban areas? They're still relying upon these global food chains, food products in the industrial development. And Jean, your talk on the language and cultural relativity of language and dominant language, colonizer, settler language, all of that was very detailed and put in a way that many of us thought about. A lot of it is from anthropology, linguistics, but you put it together in such a way that it's comprehensive for a wide audience. But I'd like to bring up the idea that we have a new language here. So it's, Jean, it's not only the future, but it's the present. We're seeing innovation in languages and words. So the coronavirus is actually forcing us, all of us, to have a new language about this. Dr. Bhattacharya, I may not have gotten your name right, but that's what you're talking about too. All of this coronavirus, social distancing, masking, all of those are new words for us. And so we are in a major era of innovation, a language change. And yesterday we spoke about the domination of biomedicine and science and scientific medicine in this discourse. And now we have misinformation. And so we're in a period of, all over the world, we're all trying to struggle and find the right words and find the right behaviors. And so we are learning as humanity to survive at this. And so I might say that I'm the director of the Global Indigenous Forum at Florida International University, and the word forum means a place for Indigenous people to bring their issues together, and in whatever way that they care to, in performance and dance and music. And Tvli, I appreciated your guitar music in the beginning. And so each community has their own way of performing in their own ceremonies, and for those ceremonies to be dissolved or hidden, in some cases, from the eyes of others, so that the communities continue to thrive in a socially, culturally appropriate way. And also this balance and mental health is very important for Indigenous peoples. So in this Global Indigenous Forum, over 7 years, we have heard all of these perspectives, and there is an international consensus on indigeneity and the Indigenous view of the world. And a lot of it has to do with balance with selves, balance with the environment and the plants and the animals. And so we are in a period of imbalance. And so how do we learn from this? And so yesterday when we were concluding, Binna said a little tiny word that was a little different way of me viewing this. And she was saying, well, that little virus is spreading about the world because humanity has come to a crisis in the environment and the world. But she was kind of, Binna, I don't want to misplace you, but your little kernel of knowledge was, well, maybe this is a little God that has come to teach the world something. And so I'm maybe generalizing on what you said, but the point I want to make in the conclusion to my comments here is, what can we learn from indigenous communities, indigeneity, from all of these talks yesterday, today, and tomorrow, where the peoples of the world, the original peoples of the continents of the world, who have had these settler impacts, who have had these colonizer impacts for generations, and have had cycles of epidemics and destruction and extermination, in this current moment, with this period of innovation, of new words, new technologies, new social relationships, how is it that we can learn from these indigenous relationships, innovations, resistance, as Jean would say, is the new future? So how can we do that? And I hope some of that comes out of this conference. Thank you.
Thanks a lot, Professor Dennis. It was amazing. You really summarized all these components so well together. I think now the floor is open, and although there are certain questions from the audience, but we would certainly like to have a discourse among yourself as well, because there are certain points which were raised by Dr. Bhattacharya, by Dr. Jean, Dr. Jacob, Dr. Patel. Dr. Dennis, if you would like to ask something, if you feel like on any of the panelists, if you have any questions to ask, other than the summarizing.
All right. Well, I think I ended with a question. What can we learn from each of your cases of how indigenous communities are responding in a way that they're going? For years, I was thinking that people who are in urban settings, who were thinking they were modern, who were thinking they were future, they were better than anybody else. For years, I was saying, if we get a world crisis, it's going to be the people of the world who are close to the environment, who produce their own foods and know that knowledge to survive. They're the ones that are going to survive.
Exactly, that's true.
And so is that what we're seeing right now?
Yeah. Dr. Patel, would you like to respond to it?
Yeah. I want to respond to Dr. Jayanta Bhattacharya. I think he made excellent points on what started. My feeling is that this whole thing has gone widespread, lies at the feet of one person, and his name is Trump, who basically bankrupted NIH and CDC and hijacked the medical people. He hijacked medicine and became Dr. Trump. I know some of your audience may not like it, but if you look at the history of CDC in the past, they've done an outstanding job. Even this time, the CDC had 23 people ready to go to China. But then he mentioned about that USAID grant that was withdrawn. So Chinese refused the CDC from going there. If you look at that history going to Africa and curtailing all the potential epidemics, we are better off. So I think it's at the feet. And look at the confusion today in America about masks, distance, everything. I mean, he's taken politics to a new level. So having said all that, forget that now. Coming to my point about Sevak project, and what can we do with the indigenous communities in the United States, for example, and even Mexico. We have a lot of ex-military medics who get out of the military. The government can hire them, train them for a week or 2 weeks. For example, in any reservation, there are ex-military people who are medics. They can hire them, train them, and put them to work in their own communities as they go house to house. For example, in a lot of Native American communities, the prevalence of diabetes is very high.
I'm so sorry. This echo is happening just because some of us have kept our microphone on. So please, Dr. Patel, you continue. You're saying wonderful, but I'll just request others to, Dr. Bhattacharya, please close your microphone, otherwise echo will happen.
So hiring these ex-military medical people, and there are quite a few of them, hundreds or thousands of them. They get out of the military after 4-6 years. They can be recruited by the government or health department, retrain them, get a curriculum for them, and put them to work in those communities. I mean, if they're from indigenous communities of, let's say, Oklahoma, they would love to go back and work in their own community. But it has to be a different mindset. How can we do this? Now, the medical establishment, and I think Dr. Bhattacharya mentioned about this, the industrial medical department. And the doctors would not like this. But the Department of Health or the state government can actually pass legislation and say, we are going to do this. And this can be done easily. Doctors are not be and all. They need to be marginalized in a lot of ways, particularly when it comes to health of the population. Let the people deal with it. I think that's enough to generate a lot of controversy.
Thank you, Professor. Dr. Patel.
Very good point. Let the community, let the knowledge be there. Good.
I've got two last words to say. First thing, during this unusual and unprecedented pandemic, we, a few doctors, have made ourselves available to the COVID patients around the clock. It's a supplementary service to government health service. Our mobile phone is always open. Everyone can call us at any point of time. And second thing is that our society, our mind, our cognition, our thinking process must not be closed. It should be open. It should be open to accept. It should be open for exchange with indigenous society, how they build up their knowledge process, how they build up their empirical knowledge, experiential knowledge. And there must be a living exchange between scientific knowledge and empirical experiential knowledge. That's all to say, and namaskar to everybody.
Dennis, now you can respond to. Yeah, please, Dr. G. Yeah.
I think there are 2 points I'd like to make. One factor that we haven't mentioned. Okay, we know that we have this opportunity to sort of look to the
voice is very much broken.
Is it? I'm sorry.
Okay.
Okay, yeah, I was going to say, we have this opportunity to look to the past, which is present, and represented by indigeneity to learn from it. But there's another totally unprecedented factor in the equation now, which is that nobody on the planet has ever experienced throughout history the number of human beings that are present on the planet at the present time. I mean, the population explosion, we're dealing with a totally new situation in that respect. And sort of there's a corollary, if you will. I'm mindful of, after those 8 years of numbness in the United States during the Bush and Cheney years, when President Obama was elected, we saw this refreshing awakening of this Occupy movement, where it was a protest movement where the occupiers of these various spaces, in and around around Wall Street and other places in New York and elsewhere, were proclaiming themselves to be the 99%, vis-a-vis the 1% of the greediest and wealthiest people. And at the time, it struck me that, you know, if we are actually going to make a revolution, so to speak, that needed to be flipped. That we are indeed the 99%, but vis-a-vis the poorest, neediest, and most marginalized 1% of the population. Because if we're not aware of them or considering them or allowing ourselves to consider them to be a disposable sacrifice for us to continue, then we're really not changing anything. And I would suggest that, and it ties right in with some of your comments, that not only is there a need for the 99% to be aware of the neediest 1%, but actually to learn from that neediest 1%, many of whom are the indigenous who have been so reduced, as Dr. Jacob was saying, and as Dennis, you were saying, that those folk need to be almost the ones guiding the discussion so that they inform us as to where, you know, whatever vaunted skills and you know, we have that are valuable can best be deployed. So you know, we have this unprecedented number of people, and then I think we have that. And I just wanted to, you know, add that to our kind of to the hopper of knowledge.
Thank you, Dr. Jean. Dr. Dennis, you would like to comment on it? You need to, Dr. Dennis, you need to unmute yourself. Meanwhile, Dr. Jacob, do you have any comment? Like, this was really insightful, the kinds of comments which came. Would appreciate your comment as well, Dr. Jacob.
Jacob, you go first.
Oh, okay. Well, I was just telling you that I couldn't hear you, but I can't comment. Well, some of the things that, yeah, like what we think about is how, again, with our current president and the issues of villainizing our public health systems is, again, another way to control our way of thinking and our way of health. And again, it's this colonized idea of like, you know, I know what's best for you and you know nothing. And even like, you know, the ironic thing is he fits within that 1% that we just discussed also. And so we're also creating this human being that we see as like, he's one of us, that a lot of the, you know, like our you know, our supporters of President Trump say he's just like us, but in reality, he's not. He's lived a life that's been good and a great life where he's been given $1 million just for turning 18, you know, and so just so he could have a startup fund for his business. And so we're in this place where we have the rich and possibly the ignorant who think they know what's right for us. And again, they're living on these ideologies of these colonized teachings that all of us have in the United States have been given within our public school systems. And so when he talks about, you know, these statues mean something to our history, this Mount Rushmore means something to us, he's talking about him specific and you know, again, not to offend, you know, the rest of the world out there, but, you know, I listened to a podcast called The Pat Down about, and it's a comedian, and one of the guys said when history was written, when the Constitution and all these things were written, when they say we the people and we are all created equal, they're not saying we, because at that point we were 3/4 human beings. We were not fully human. What they were talking about was white male Christians. And that's still the belief system that we have and we live on. And that's kind of like the the issues that we're going to experience for now and maybe for a few more years. And again, another way in which our pandemics and epidemics will continue growing because we're allowing ourselves to give into this ignorance. So go ahead, Dr. Weidman.
May I say something before, please?
Sure.
Thank you for everybody. I just want to make sure that not all the discourses come from the US, because there are other indigenous peoples outside the US that also, I know the president of the US have a lot of power and, and directly impact on other politics from another countries, but, things are happening in all over the places. So just to make sure, just to take it out from the US, because this is actually being done in India and there are people from other places. So now, just after saying that, although I'm, I also belong to the same university, other researchers here, that was my point. But Dr. Bhattacharya, I'm sorry if I cannot pronounce your name correctly. I'm going to, let me put some emotions on that. I love your presentations. I love your presentation. I myself and also been an anthropologist, a sociologist, but I'm a chemist and I do molecular cell biology. I'm waiting for read that presentation because you put it everything, and also how occidentalized the medicinal system had, we have these politics of diseases. And sometimes we have some people, like I said before, they don't have access to that, and they rely on other system. But also Dr. Patel say at this moment, yeah, you can go to the priest, you can, do your rites in 5 days, you are going to get okay. But in the meantime, just go to the other doctor and, provide things. So sometimes we can get interconnected. I'm really waiting for read your presentation because have so many things I couldn't take notes, and stuff like that. Again, thank you everybody. And just to make sure, we are living in other places other than the US.
Exactly. And I was just speaking from where I'm from. And sometimes, I think us Americans love to have the ownership of ignorance. But I know that as in my presentation, colonization happened all over the world. So thank you for emphasizing that.
Yeah, and Gene's talk, he talked about the words and the importance of language. And our discourse right here is in English. It's the colonizers' language. And we're using it as the Franco lingua for these many countries to come together here that BINA has organized us. And just the kinds of things we're talking about. And it's reflected, the colonizer language is reflected in the things we say. And so here I am reflecting to make sure that I didn't say anything that was dishonorable or disrespectful. And I can see that in my question was, what can we learn from indigenous communities in their responses here? That word we, that little pronoun has a great importance. And so who is the we? And so I would like to, if I had another word, I would like to turn this around, that this whole seminar should be for those representatives from the indigenous communities who are listening to this, for us, I'm at a loss of a pronoun, for the indigenous peoples of the world to benefit from this knowledge that's being shared, and also to be empowered, because what they're able to hear is the various communities around the world, their circumstances and the conditions and the variation of responses. That should be very important for communities to say, yes, what we're doing is okay. Let's just keep going down this route. We heard that from this community in this part of the world, and it works. And so it's empowering. I hope this whole seminar is empowering. Thank you.
Dennis, you made the point, I think, much better than I did. That was exactly what I was trying to get to with the 1% idea, and the fact that it's it's less a question of the scientific community trying to figure out how to fit in indigeneity, as what is really relevant is for the global indigenous to assign the modern science its role based on knowledge that is arguably just timeless. I would like, Maria Luisa, thank you for bringing that up. I'd like to just reiterate a point I made yesterday too. Beyond language, not only are we're using a colonizers colonizing language, but we're using it for our purposes. But in the same way, here we are benefiting from this wonderful technology that allows us in different time zones to be holding a conversation on different continents. But the hardware that makes this possible is this rape of the Congo and Africa and these other places for these, rare, coltan and tanzanite and cobalt and these rare materials that, companies like, Dell or whoever have to use to make this. And the people, the children who, I would invite you to just Google search, child labor in Africa or in the cobalt industry, and to see little children who should be in school learning life skills and socializing out here toiling in a kind of mining situations that are also just like strip mining, devastating to the environment.
Gene,
we really need to address that.
Gene, let me tell you something. My dad was a miner. I really know that situation.
Yeah.
My dad was a miner, and I grew up in different mines. And I began school when I was 9 years old. And this is my third language. Yeah. So I know that situation.
Yeah.
Thank you for all your comments. It was really a remarkable session. Whatever we did yesterday, we started with yesterday, it ensued the whole discussion further. And I'm really glad that we all could initiate an interconnected cross-cultural dialogue. Definitely, Maria, it's not going to be American perspective at all, because tomorrow we are going to have more Asian voices, not only South Asia, but also from Central Asia. And there is going to be another aspect of Africa as well, because, many a time we take the settler colonialism part only in US, but there is a whole settler, not only in US, the entire American continent, there is a whole settler colonialism still existing in Africa as well. So what are the voices from there? So tomorrow, a friend of ours will be actually from a settler community. So how he perceives the whole idea in being a white in an African continent. So, and how it is going to affect. In fact, there are so many dynamics to indigeneity, and we somehow we have to deconstruct the whole anthropological narrative itself, because it's all stereotypical Eurocentric. There is like, if you could see the dais at present, we all are indigenous. You are indigenous, Dr. Patel is indigenous, I am indigenous, Bhattacharya is indigenous, Jacob is, so we all are indigenous, and we are not the stereotypical anthropological narratives. We are different. And we have lived different truths, which all are truth. So I really appreciate it. Was a wonderful session. We had great points of arguments, which are not going to end here, which will ensue in many more dynamics and dies. And I hope we all will connect further in different platforms, not only in just about discussing, but we will be able to connect even in terms of empirical research and empirical works, where we will be practically implementing what we thought about. I once again thank you all for your valuable time giving to us. You have been really kind. So yeah, I would really appreciate if there are some last words to say. Thanks a lot for all of you. Yes, Dr. Patel, you would like to say something?
This was an excellent conference. I learned a lot. And I really appreciate you inviting me, and I also appreciate all the speakers and Dr. Widman for getting us all together. Thank you.
Thank you. Oh, and by the way, the new global settler narrative is now Chinese as opposed to English. So that's another thought.
Exactly. We have to learn Chinese for that matter. Thanks a lot, sir.
Thank you to everybody.
Yeah. Thank you, everybody, for sharing your wisdom, your words, and the perspectives of the people that you're closest to around the world. Thank you.
Thanks a lot. Thank you. And yeah, we'll be sharing this whole thing on a YouTube, and we will be sharing that link with you sooner, hopefully very soon. Thanks a lot. Yeah, sure. You need to unmute yourself. Dr. Jayanta, you need to unmute yourself. Let me try if I can unmute you. No, I can't. You need to unmute yourself. I'm so sorry you got muted. You have to unmute yourself, Dr. Jayanta. You can call me, otherwise I'll put you here. No, I'm so sorry. You have to unmute yourself on your own. Oh, there are some technological glitches. And if you all are interested for tomorrow's talk, tomorrow's panel, you just ping me or you just message me, and I will share this link to you. Actually, we have not shared all the links to all the panelists because of your own preoccupations, because you all are busy people. So not everybody was available for all the 3 days. So if you would like to join for tomorrow's panel as well, you can tell me and I'll share the link with you.
Now you can hear me?
Yes, we can. Please. Yes, sir. Yes, Dr. Jayanta, what do you like? Please add to your comments. Oh no. Oh, he got disconnected again.
Here you go.
Yes, you
now
can.
Now you can hear me?
Yes, we can hear you. Please, sir.
Yeah. It was a very engrossed engagement, and it was a very productive meeting, seminar, and big thanks to you for organizing this thing. And good night, and namaskar to everyone.
Yeah, it's a dinner time for us, and you all please do have a good lunch. We failed to give you a good lunch. We really would like to host that part.
It's midnight. It's going to be midnight here now.
Yeah, actually, we really love to host you all to host a nice lunch, but it's unfortunate because virtual thing cannot let us do that. So please do have.
We will have virtual lunch and dinner.
Definitely, we'll do that.